I'm extremely happy to invite our senior resident, Dr. Laya, to carry forward with the further proceedings. Over to Laya, please.
Thank you, ma'am. The first session is on neonatal updates for the practicing pediatricians by Dr. Suman Rao, Professor of Neonatology, St. John's Medical College Hospital, Bangalore, chaired by Dr. PMC Nair, sir. He was a HOD of SAP Hospital and then in Sree Gokulam Medical College, and now is a consultant in PIMS Hospital. We welcome PMC, sir, to introduce the subject and the speaker. Over to you, sir.
Hello. Thank you, Leah. Am I audible?
Yes, sir.
Okay. Very good morning and a warm welcome to each and every one of you to this excellent Gokulam Pediatric CME, which actually is the brainchild of our beloved principal, Dr. Lalitha Kailas. I have been the opening batsman for about 6 CMEs, as HOD Pediatrics for about 10 years and head neonatology for 15 years, till I retired in 2020. This Gokulam Institute or this alma mater is very close to my heart. So pranamam to Sree Gokulam Gopalan sir, our beloved chairman, and to director Dr. Manojan. And today's topic is very useful for the general pediatricians, because 30 to 40% of newborn infants are seen by the general pediatricians in their day-to-day office practice. And to speak to us on this topic, we have none other than Dr. Suman Rao. She is the professor of neonatology, St. John's Hospital, Bangalore, and a good friend of mine for many years. She had her MD from MMC and DM neonatology from Mumbai KEM. She received the gold medal for social neonatology for KMC. She is a prolific speaker, and she has more than 100 publications in national and international journals. She is also a consultant in WHO, especially for the IKMC trial. She has done multicentric study on IKMC, that means immediate kangaroo mother care, and she is a national consultant also. One thing what I have noticed is whenever I attend her presentation, I learn something new. So let us hear from her. Let us go to Dr. Suman Rao. Okay. Madam.
Thank you very much. Thank you, Lalitha madam. Thank you, organizers, and a special thank you to Dr. PMC Nair. Your message yesterday sort of triggered me to know that, yes, I have a talk to give today and I have to prepare for it. So I'm glad that I'm able to do this. At least there was 24 hours notice. So my topic today is what is the update for the pediatricians from the neonatal front. So obviously, this is a very, very large topic, and I hope I do justice. So I will start off right away. So the preliminaries on any online meeting, can you hear me well? Can you see my slides?
Yes. Yeah.
Okay, yes. Thanks very much. And for the next maybe 20-25 minutes, let me take you through what is the update for practicing pediatricians. What is what I should change today? And whenever I focus on any topic, the first thing that comes to my mind is, can India achieve our newborn action plan goal of single-digit NMR by 2030? I know Kerala is way ahead. You have already achieved it. But what about the rest of India? And when we look at the big 3 causes of mortality, prematurity, sepsis, and asphyxia. So almost all my talks are revolving around this, and that is what I'm going to be speaking today too. What can the pediatrician do newly or differently in 2022 as far as for the normal newborn? What are the delivery room interventions? What about newborn screening? What are the interventions that the pediatrician should know about the preterm, which have large, huge impact? And also, what is the current stand on asphyxia management, and maybe a little bit about infections? But please bear with me. Yes, it's going to be evidence-based, but a lot of it is going to be laced by my own experience. And pardon me if it is going to be very, very biased. So with this disclaimer, I would like to start off, and we go right into the delivery room. As you all are aware, every 5 years, ILCOR comes up with guidelines, and this is the 2020 algorithm about newborn resuscitation. And I'm going to focus on 4 key areas where there is new things happening. And things that a pediatrician would need to do in your routine, taking care of babies, attending deliveries. And the first and foremost, the first two are for every baby that you're going to attend, whose delivery you're going to attend. And one is going to take 1 minute. The other one is going to take 1 full hour. And we have to be patient. So delayed cord clamping is the current norm. And in fact, it's so important that even in the 4 pre-birth questions, in 2020, this has changed to include for us to discuss even before birth, to plan ahead and say, what would be my umbilical cord management plan? And all term babies and preterm babies should have delayed cord clamping after 1 full minute at least. This is a very, very strong recommendation. And initially in 2010, it was only for term babies. Then in 2015, we got data for preterm babies. In fact, the data for preterm is much more robust. If we see, this is a meta-analysis for preterm babies and delayed cord clamping, you see that the number needed to benefit is only 33. That means in a day, in a very high volume center, if you do delayed cord clamping for preterm, 33 preterm babies, you can go home and be happy that you saved 1 life. And Kerala also has a big contribution to this data. One of the work which was done by Thomas Ranjit, who is currently in Cochin, when he was in Johns, that is delayed cord clamping randomized control trial way back in 2010, is also part of this meta-analysis. But the big question was, what do we do for babies who need resuscitation? And that's where, again, at Johns, we looked at a randomized control trial where can we do umbilical cord milking? So we cut the umbilical cord at 25 centimeters and did milking 3 times. And this itself helped the babies, and it resulted in better ferritin status, better iron status at 6 weeks. So there is now the update doesn't state that we should do milking, but this is one option for babies needing resuscitation. And we found there were huge benefits, not only in hematocrit, but also in MAPS, and these are all supposed to improve the neurodevelopmental outcome of these babies. What else could be the choice for babies needing resuscitation? We have other work going on in India, and this is one which is done by Mangala Bharati's team, where they are looking at resuscitation on intact cord, where you have this kind of equipment which you wheel next to the mother, and with the umbilical cord, you continue resuscitation. And this will probably become the new norm, where you will have such kind of resuscitators in all delivery rooms. The next intervention is about skin-to-skin contact. Now, this has immense benefits. It helps in better cardiorespiratory stability, better transition, better glucose stabilization. It gives the correct microbiome to the baby right from the word go. And of course, it helps in breastfeeding. Not only that, it improves the neurobehavior and neurodevelopment even as late as 10 years of age. And the evidence is very robust. And therefore, step 4 of BFHI is now modified to say that you need to keep the baby in skin-to-skin contact immediately after birth for at least 1 hour and encourage the baby to breastfeed in skin-to-skin contact. But what is new about this? This recommendation has been there for 10 years. The big challenge is that we still have a gap. And I must say that even in my own institute, I haven't still managed 1 hour of skin-to-skin contact after birth. But we did like to try to look at it in a systematic manner. What are the barriers and enablers? And we found that, yes, the basic thing is system barriers, lack of personnel, time constraint, knowledge barriers where training and awareness will help. But main thing is the fear, concern for safety of the baby, because yes, sudden unexplained postnatal collapse is known when skin-to-skin contact is done. And therefore, we need to make sure that the whole system is geared towards doing this, at the same time making it safe for our babies and getting our obstetricians' confidence in this. And therefore, this is a team effort. It is an important evidence-based intervention, and we all need to strive towards it. The other thing in the delivery room is mainly for less than 32 weeks, may not be for all practicing pediatricians, but cling wrap is now recommended for babies less than 32 weeks to maintain temperature. So that was about skin-to-skin contact and delayed cord clamping. I love this figure because this gives us a good history of what has happened about the delivery room management of meconium stain amniotic fluid. Way back in 1998 and 2004, we were talking about us going in between when the baby was delivering and just when the head was out, trying to do oropharyngeal suction. That went out in 2000, and we were now left with only doing endotracheal suction for non-vigorous babies. I'm very proud to state that this change in recommendation, that nowadays we say that even if a baby is meconium stain amniotic fluid and baby is not vigorous, even then don't bother with endotracheal suction. Go ahead and do positive pressure ventilation, because giving a breath is more important. And it is the Indian studies which has made these recommendations, starting from JIPMER and then in Dr. Nangya's team in Lady Harding. So this one is now the Cochrane meta-analysis, which is again by Indians, has shown that no intubation for non-vigorous babies, no tracheal suction, just manage and give a breath and save a life. The last delivery room intervention I would like to talk about is safe respiratory support. These three equipment, that's a pulse ox, a blender, and a CPAP, are now no longer optional. Every delivery room should have them. And if we give oxygen, first of all, we know that room air resuscitation is the norm, but if we give oxygen, it has to be blended oxygen. And the whole focus is on ensuring that in the first minute of life, every baby takes an effective breath. And remembering the mnemonic, Mr. SOPA, is very vital for us to do effective resuscitation. So these were my 4 updates on delivery room interventions for the practicing pediatrician. Now we go to something that you need to do in the postnatal wards. And I know again that Kerala is very, very ahead in this. So only when you're able to save lives, we now focus on screening. In fact, WHO also recommends that when your IMR is less than 50, you should offer screening. And therefore now India as a whole should look at screening. And when we look at screening, we have different categories. For all newborns, you at least have to look at screening for hearing and a metabolic one, which rules out congenital hypothyroidism, congenital adrenal hyperplasia, and G6PD deficiency. That's the minimum you need to do. But maybe in Kerala, you need to move beyond. You need to maybe look like it as a resource-rich country and even do more. So let's discuss this. The first and foremost I'm going to discuss is hearing screening, where again, you'll have a very well-developed hearing screening program. We know now that we have to pick up and rehabilitate a baby with congenital hearing loss within 6 months to ensure that the language is good. Otherwise, there is going to be language deficit. Risk-based screening is not good enough because it misses 57% of the babies, and we need universal hearing screening. In St. John's, we have been doing universal hearing screening for almost 20 years now because we showed that risk-based screening misses a lot. In fact, even in our community centers, we have the St. John's rattle, which is used for universal hearing screening. So what is recommended is either OAE, or for the high risk, it is the AABR methods of hearing screening. So these are the recommended methods, and every baby before discharge should get it. What is recommended by the JCID position statement is that screening should not be delayed before 1 month, confirmation by 3 months, and intervention by 6 months, where you rehabilitate the babies. And even a cochlear implant is possible in a child as young as 1 year old. This was the 136 protocol we know. But in 2019, JCID said, yes, 136 is good, but you should try to make sure that you do it in 1, 2, 3. So that by the time the baby is cooing and hearing, you need to get the baby rehabilitated. So the new thing is, please try to follow 1, 2, 3 protocol. Next thing is about the metabolic screening, heel to heel, HEEL to HEAL. Every baby should get the basic minimum one, preferably after 48 to 72 hours. But if it is done within 24 hours, you need to rescreen later. And for sick infants and preterm infants, screen by day 7. What about TMS? We know that TMS is one test which can detect many abnormalities. And do you think we are ready for TMS? The rest of India may not be, but I do think that Kerala is. This study from Goa showed that the combined incidence of these disorders is 1 in 230, which is quite common. And you now have diagnostic tests available, you have treatment available, and you have support by groups like Organization for Rare Diseases in India. And therefore, I see no reason why states like Goa, Kerala, which have really attained fantastic NMRs, should not progress to TMS and do this expanded screening. In fact, even NNF says that in a high resource setting, all units should get the expanded panel. In addition to these screenings, which is recommended, we also have the critical congenital heart defect screening, which all of you all know about, which is done after 24 hours. But the update in this is the screen, which used to be done, repeat screens twice. The recent pediatric study has shown that just doing a one repeat screen is enough. The false positive rates are not too high. So the modified CCHD screening says, if a baby fails the screen, you repeat it after 1 hour only once, and then go on to do the echo and all as necessary. The next thing I want to talk about is bilirubin screening. I don't know how many of you all do universal bilirubin screening. We debated a lot for 10 years in Johns. We used to do risk-based screening, but people also do universal bilirubin screening either by blood test, by plotting on this, or by TCB. And I had the opportunity while working for WHO to do a systematic review on this. And we found that universal bilirubin screening definitely reduces readmission for jaundice and severe hyperbilirubinemia. And therefore, based on the systematic review, the new guidelines which is going to come out is going to be, the WHO recommendations is going to be recommending universal bilirubin screening for all normal newborns. I must give you a small update from WHO. WHO has recently revised both the postnatal care guidelines, which is going to be released at the end of this month. So please watch out for it, and the low birth weight guidelines. And some things which is going to come out is on screenings. So you might be wondering, why am I talking of screening as an update? Because we are going to have new recommendations on universal bilirubin screening, hearing screening, and eye screening. So screening is the new norm, and we need to do it for all our babies. So next, I would like to talk about interventions for preterm infants, and I would like to go very quickly through this because this is what the practicing pediatrician should know, may not be what you practice all the time. I don't know whether you're aware that there was a large controversy on the ACT trial. The ACT trial was a cluster randomized controlled trial to scale up antenatal corticosteroids, and they found that instead of benefiting, it actually increased perinatal mortality. And that's when everyone said, okay, we have to halt scale up. And WHO quickly convened and came out with criteria to give antenatal corticosteroids. You can't give it to every Tom, Dick, and Harry. You can't give to every woman who has a precious pregnancy. And then WHO took up this large randomized controlled trial with more than 6,000 women to look at the safety of and efficacy of antenatal corticosteroids. And I was also glad to be part of this trial, which got published in NEJM in 2020, which has clearly shown that the controversy can be rested. Antenatal corticosteroids is beneficial. Now what the WHO is doing is looking at whether it is useful for antenatal for late preterm infants, because we know that in late preterms, though RCOG and ACOG recommends, it also has harm. The number needed to harm by causing hypoglycemia is only 35. So this study is looking at, is it beneficial? And it in fact has 3 arms. One has standard dose and the other also has a low dose corticosteroid. So this result will be out. It is yet to start, but it's all in process in another 5 years. The next intervention I would like to talk about is Kangaroo mother care, something which is very close to my heart. And we know this is one game changer with a huge reduction in neonatal mortality and various other benefits. Not only that, it supports development and improves neurodevelopmental outcome. But what I would like to update you is in a trilogy of WHO studies, which showed that Kangaroo mother care needs to be even utilized better. And I start with the immediate KMC study, which Dr. PMC and I talked about. And this was what initially I got employed for to support this trial. And this was a randomized controlled trial in 5 countries, which started KMC in low birth weight babies, less than 1.8 kg, immediately after birth, irrespective of their stability. Even babies on CPAP, respiratory support got KMC. And in fact, a mother newborn ICU was created so that mothers could be in the NICU to give continuous Kangaroo Mother Care, and she got all her postnatal support in this mother newborn ICU. And you have some write-ups on this in the recent Indian Pediatrics too. All respiratory support was given in Kangaroo Mother Care. And what really surprised me is that the mean duration of KMC in this study was as long as 17 hours per day. And the impact was huge. Even in the control arm, where they did very good KMC of 20 hours by discharge, by doing immediate KMC, the reduction in mortality was 25% more. And it in fact reduced infections and hypothermia too. And therefore now the new WHO recommendations will surely talk about starting immediate KMC for even the unstable baby and having a paradigm shift in how the NICUs are going to be constructed. If you're designing a new NICU, design an MNICU so that you have zero separation of the baby. This second series of community-initiated KMC showed that the benefit is not only for less than 2,000 grams, but even between 2 and 2.5 kgs, there's a huge benefit. And you can initiate Kangaroo Mother Care even in the community. And that's another new recommendation, and that has huge benefits throughout infancy. The last part of the triology was that the scale-up KMC study. This was again something that we were involved in. We were a site in Karnataka. And this shows us how to scale up KMC from less than 5% in a population to more than 60% in a matter of just 2 years. We know we all struggle. We know KMC is great. We know breastfeeding is great, but how to make it happen? And this publication in BMJ Global Health last year will give you the how to do it. The third most important intervention for preterms is CPAP. I want to emphasize it again and again. The first intervention for preterms for respiratory support is not oxygen. It has to be CPAP. It reduces mortality, it reduces the need for surfactant, it reduces the need for up transfers. Then again, a peek into the new recommendations. We are going to have new recommendations on use of probiotics and use of caffeine, conditional recommendations for the preterm. That was my big chunk on preterm. And I think the last 5 minutes I'm going to use on asphyxia, because we all know there's a huge controversy on asphyxia. Your question is it cool to cool now? Should I refer a baby who's asphyxiated to a cooling center? That is your question as a pediatrician. And we know that there was large amount of data, Cochrane meta-analysis showing it is beneficial. In fact, it is also recommended in the new NRP. It saves lives. We have huge Indian experience, but the Helix trial, which came out last year, created a controversy. This large multicentric trial showed that though the primary outcome was not different, one of the secondary outcomes, that is mortality, was higher in the cooled one. And therefore, there was a question of whether we should really cool it all in low and middle income countries. And what really created the hype was not the paper as much, but this other paper, which was a review article, which really took off and called even cooling a malpractice. And that's where NNF quickly brought about a position statement, not just a consensus statement, it was evidence-based. And what does this NNF position statement says? That one of the things, when they looked at, I was part of it and Dr. Manoj was part of it, and we looked at the mortality before discharge, you need to have a CORD ABG. And when you have a CORD pH less than 7, cooling is still beneficial. You should not have hypothermia on admission. And in presence of severe encephalopathy, the risk of death is high, and therefore you need optimal quality care. So there are clear-cut recommendations for cooling practice given by NNF. And what you as practicing pediatrician need to know is, if a baby is asphyxiated, it makes sense to collect CORD ABGs for all babies. If a baby is asphyxiated, send them to a good cooling center, which not only has good results, but also has good follow-up. And send them well so that they are not hypothermic on admission. So this is the message for cooling. Cooling is still cool, possibly if it's only done in the good way. In fact, we have new cooling devices. We know now that servo-controlled device is a must. And this is something which is going to be soon out in the market, which is an Indian servo-controlled device, much cheaper, and it also could be integrated to have AEG. But cooling itself is not enough. We need to look beyond. And what is beyond are two things which may come up in the near future. There's a lot of evidence, but it's still not into guidelines. That is erythropoietin and melatonin, and it could be used for longer periods even after the asphyxial event. The last thing on asphyxia is which anticonvulsant to use. Last year, we had the results of this trial, which again found, there's so much of controversy. People are using levetiracetam. We also did a study. We found that levetiracetam and phenobarb were as good. But this NeoLev-2 trial, a large multicentric trial, showed very clearly that phenobarbital was more effective, though it did have more side effects. So the search for the best anticonvulsant in the newborn is still on. So these are my conclusion. I've taken you through the normal newborn, screening, preterm, asphyxia, but you're going to ask me, you haven't talked anything about infection. I don't have an update. We have many papers which we have done on infection control, but what I want to emphasize is it is basics, back to basics, which is going to control infection. You're not going to find any great update on in the literature. What is important, we need to do the right thing, like hand hygiene, universal precautions, taking care of lines, and quality improvement is a way to go about it. And if we make sure that the mom is in the center of the universe, that is, mom is there in the NICU, it's a family-centered care, infections will automatically come down. So with that, I conclude my presentation, and I thank the organizers again for this. Thank you.
Okay, thank you, Dr. Suman Rao, for this fascinating talk. I'm sure mother newborn ICU will be the norm very soon, at least in Kerala and Bangalore. It will be very interesting and nice. Any questions from the audience? Just 30 seconds. I think nothing is in the chat box, I think. So I think we are kept to the time, and we shall conclude the session. Thank you, Dr. Suman Rao, for that fascinating talk again. Dr. Lalita.
Yeah, thank you, Dr. Suman, for that excellent talk. You had taken us through the whole of neonatology for the practicing pediatrician regarding the latest update. And once again, very sorry for the inconvenience caused to you at the last moment, but you had done it with such a short notice. I think it's an excellent. So thank you. And thank you, BMC, for effectively moderating the session. And thank you all the viewers.
Thank you.
Now, I think, shall we move on to the formal inaugural function? I could see Dr. Ramesh has joined, so welcome, Ramesh. I think without wasting time, we shall move on to our formal inaugural session.
Now we will move on to the inaugural function. I would like to invite Dr. Lalita Kailas, Professor of Pediatrics and Principal of Sree Gokulam Medical College and Research Foundation for the welcome speech. Over to you, ma'am.
Distinguished Chief Guest of the Day, Dr. Ramesh Kumar, National IAP President, and the State IAP President, Dr. Vijay Kumar, State IAP Secretary, Johnny Sebastian, Trivandrum IAP District President, Dr. Rukmani, President, Dr. Sibi, Dr. Riaz, the National Executive Board Member, and I could see all the other Dr. Jose, and all the faculty members, chairpersons, and all the senior faculty members, my teachers and my colleagues. Very good morning to one and all. I am extremely happy to welcome you all to this 8th annual CME of Gokulam Medical College, organized jointly by the Department of Pediatrics as well as by the IAP Trivandrum District Branch. Though the COVID is the pandemic is gradually declining and the COVID relaxations are there, but still we thought we'll continue this time also on the digital mode. Of course, we know that having it in the digital mode has got its own advantages and disadvantages. Advantage in the sense that only because of this being conducted in a digital mode, we are really fortunate to have such a galaxy of speakers, that is the who is who in the pediatrics at the national level, to share their expertise with us. The disadvantages, of course, we know that it lacks the warmth and joy of the physical togetherness as well as the sharing our relationship. So moving on to however, now we have learned the new way of adjusting. So I think the conferences are going to stay mostly in the digital way or maximum in the hybrid way. So moving on to the pleasant duty of welcoming the guest of the day. I have very proud and privileged to welcome Dr. Ramesh Kumar, the National President, with us to inaugurate this function. I just witnessed the last week, that is the National Pedicon in Noida, the reception, the warmth with which he was received in that reception, and really during which he had taken over as the national president-elect. And though he had the hectic schedule there for the rest of the week, and he had been to Kerala only 2 days back, he had readily agreed to our invitation to be the chief guest and inaugurate this function. Thank you very much, Ramesh. I'm really extremely happy to welcome you to this session, and also I wish the very best, because for your the next 1 year during your tenure as the national president-elect. I'm sure that his leadership at the national level will rejuvenate the association and bring the association to much higher and higher heights. And I wish the very best, and I'm extremely happy to welcome you to this inaugural function, Ramesh. The next, we have Dr. Vijay Kumar, who is the state IAP president. IAP president to address this gathering, a very soft-spoken, excellent academician, and a gentle person, and a pediatric endocrinologist. Amidst his busy schedule as the HOD of Pediatrics in the Government Medical College, Mancheri, and also because he said he has some other engagement in another endocrinology meeting, but he had readily agreed to our invitation. Thank you so much for that. I very warm welcome to you, Dr. Vijay Kumar, to our function. Next, we have Dr. Johnny Sebastian, the vibrant secretary of the Kerala State IAP, to offer felicitation for us. Though I know that at least he had conveyed to me that he is enjoying his vacation in Shimla, but he's magnanimous enough to spare his time for us. Thank you, Johnny, for being there with us. And next, we have Dr. Rukmini, who is the president of Trivandrum IAP district branch, to offer felicitation. And within a short span of time, Dr. Rukmini had shown her skill as a very efficient organizer. Very warm welcome to you, Dr. Rukmini. I am also extremely happy to welcome Dr. Riaz, who is the National Executive Board member. More than an official capacity, Riaz is always close to me, initially as my student, then later as a colleague, and now as a real true friend. Welcome, Riaz. And then also we have Dr. Sibi Kurian with us, the secretary of the Trivandrum IAP district branch, a very vibrant, active member who always thinks of IAP day in and day out. I'm extremely happy to welcome you, Sibi, who is here to offer the vote of thanks. And also I take this opportunity to welcome all our esteemed faculty members. We have already heard Dr. Suman Rao. Thank you so much for making it at Suman, and very warm welcome to you. And Dr. PSN Menon, sir, from Kuwait, he had really agreed to my invitation. Thank you, sir, for being there with us, and a very warm welcome to you. And also we have Dr. Gauri Shankar and Dr. Vijay Bhaskar from Chennai, and very warm welcome to you both. And Dr. Kashi is going to join with us, and Dr. Upendra is also going to join, and Dr. Sendil. And I very warm welcome to all of you for taking Sunday on this, taking your time on this pleasant Sunday morning. Welcome all. And then also very hearty welcome to all our chairpersons. Already we had heard Dr. PMC Nair, and then we have others, like Dr. Riaz is there to chair the session by PSN Menon sir, and Dr. Ajit Krishnan, Dr. Shaji, Dr. T.U. Sukumaran, Dr. K.E. Elizabeth, all of them for agreeing to be with us this morning, and a very warm welcome to all of you. And all the other participants, actually the viewers and the delegates, are the most important part of the session, and I extend a very warm and happy welcome to this CME. I'm sure that you're all going to enjoy this academic feast delivered to you by the faculties of the National Rescue. So let me conclude once again, extending a very warm welcome to all of you. Thank you. Thank you all.
Thank you, ma'am. Now I'd like to invite our chief guest, Dr. Ramesh Kumar, IAP National President, for formally inaugurating this function.
Thank you, Lalitha ma'am, for that sweet introduction and sweet welcome. President IAP Kerala, Dr. Vijay Kumar, President-elect, National Executive Board member, Dr. Joso, President IAP Thiruvananthapuram, Dr. Rukmani, Secretary Kerala, Dr. Joni, Secretary Trivandrum, Dr. Sibi, organizing team led by our vibrant former HOD of Pediatrics at SAT and our dear ma'am, Dr. Lalitha Kailas, my teacher at Kottayam, Program Director, Dr. Gobinathan, and my dear friends was always there, Dr. Shaji as the organizing secretary, and the team at Sree Gokulam, Dr. BMC Nair, and all the seniors, and the faculty, a great faculty team. I could Dr. right from Pearson Menon sir to Dr. Suman Rao and Dr. S.J. Kashi, the Immunization Committee chairman, as well as my dear Dr. Gauri Shankar and Dr. Vijay Bhaskar and Dr. Upendra joining, chipping in later, and all my dears in IAP Kerala, the mascot of IAP Thiruvananthapuram and IAP Kerala, Dr. Riaz, and all my dears, especially Dr. Ammar Nair and all seniors I can see, and Dr. Past Secretary Dr. Balachandran, and well, all my dears who are joined on the platform. A differently pleasant morning here today, I feel. After being in the physical mode, FaceTime mode for about 6 days or 7 days at a stretch, back again to the webinars, and that looks a little different. All are smiling, all are very cozy and comfortable in their own spaces. And even I am very comfortable at home with a meeting coming up, but attending meetings and in your own den, I feel. So that brings a different feel, as Lalitha ma'am suggested. It has got its own plus and minuses, the webinars. But I believe this year belongs to physical mode. I would like to believe, because the webinars, the COVID fourth wave will not be there. We have around 700 academic workshops coming up for the year, lined up for the year. So you all would really want only for physical time, only for physical mode. So 340 branches, 700 academic workshops lined up for the year. So you really have enough time, enough activities apart from the conferences by your own team and the CMEs from your own branch. This is Central IAP academic sponsored workshops. At least 1 lakh each for every workshop for 700 modules for this year is already lined up. So please, I believe all the branches should be really be prepared for the great activities in the offing. And I'm always happy joining this the Sree Gokulam activities, and I always love to come there even when I was in Bandalam, but I missed it a visitor many a time for some or other reasons. And it's the 8th time. I always believe it's something like a IJPPC journal. It's always for the practitioners. All practical topics relevant for that particular, maybe at the scenario or the juncture is always included as a topic in Sree Gokulam CME. So congratulations to the team at Sree Gokulam, especially Lalitha ma'am, Gopi sir, Shaji, as well as PMC sir, and all seniors for making it happen, and all your supporting faculty, and all the faculty who are joined for the day. And well, I must at this moment, I must thank all my dear friends of IAP, the Central IAP as well as IAP Kerala, who really participated and involved in the Pedicon Noida in a big way, made it an occasion and for celebration on one side, scientifics on the other side. It was always moments to cherish. Personally from my side, more than me, it's my friends in IAP Kerala who really cherish the moments. I am very, very certain about it. And even I had, my wife was, Jaya was suggesting that your friends seem to be much more happier than you at every moment, that they are really enjoying these moments. So I am so proud about it, my dears here, and you all gave me the responsibility, and I need to live up to it. And I am pretty certain that I can live up to, with all your blessings and the divine blessings, I can live up to your expectations and live up to the responsibility which is shouldered on me by my dears in IAP Kerala and of course across the country. And of course from the academic side also, Pearson Menon sir and Vijay Kumar, we had enough academic TOTs, and all the seniors chipped in with their academic contributions as faculty. They really were so thoughtful and resourceful during the scientific sessions. Almost everybody joined all the functions, inauguration, all dinners, the celebrity nights as well as, and we had, I mean, all of you really loved hearing that Minister of the Child and Human Welfare, Madam Smriti Irani, and we had a lot of happenings afterwards with the Women and Child Development through the Anganwadis, ICDS. We have got a lot of activities in the offing from the ministry itself. So that's going to be a good year on all aspects, but we need a lot of work ahead for my members. So I'm sure this is an year where IAP has been doing good over the years, doing well. And if there is not much of COVID keeping us away from the physical mode, I think this is the time when we really look forward to having some social contacts and living up to our academics and friendship alongside. Thank you very much. And formally, I'm so happy to have the conference formally inaugurated on one side with all your wishes and good thoughts. And again, my best wishes to all those who have joined for the academics here today, and wish the Sree Gokulam team also a very good time ahead in academics and professional side. And for the IAP Kerala and IAP Thiruvananthapuram, another great year with Vijay Kumar and Dr. Rukmini with the supporting Dr. CB as well as Johnny around. Thank you very much, and I wish you a great day. Thank you.
Thank you.
Thank you, sir. Now I'd like to invite Dr. Vijay Kumar, President, IAP Kerala, for the address.
Respected Dr. Ramesh Kumar, the National President of IAP, respected Dr. Lalitha Kailas Madam,
yes, I can.
Organizing Secretary of the meeting, and Principal Sree Gokulam Medical College, and my respected teacher, and Dr. Riaz, the Central EB member, and Dr. Jose O, the President-elect of IAP Kerala, and Dr. Johnny Sebastian, the Secretary of IAP Kerala, and the pillar behind all the programs of IAP this year and last year also. And I'm very happy to say that we have won last year the best branch award in the state, and I congratulate Dr. Johnny and Jayaraman sir for that. And Dr. Rukmini, the President of IAP Trivandrum, Dr. CB Kurian, Secretary of IAP Trivandrum, and Dr. Chandramohan, Dr. Gopinathan, and Dr. Shaji came of organizing team of Gokulam. It gives me an immense pleasure to be in the inaugural function of Gokulam Pedicon, the Gokulam CME, the annual CME conducted by Gokulam Medical College and Research Foundation. And for the past few years, it was shown an immense academic activity by the Gokulam. And today, this time, this was in virtual platform. And we have eminent faculties from all over India and abroad to enlighten the various fields in pediatrics. And I'm sure that this will be a great learning experience for the pediatricians in Kerala. And it is very much appreciated because now even at this time, we have more than 100 participants in it. And I wish the program a grand success. Thank you, Jai Hind and Jai IAP.
Thank you, sir. Now I'd like to invite Dr. Johnny Sebastian, Secretary, IAP Kerala, for felicitation.
Johnny?
I think Johnny may be having some network issue, madam. It's not there in the participant list.
I saw you earlier, he could chipped in actually.
He was here actually.
Okay, Leah, then we can invite Dr. Rukmini is the next person. Leah, you're muted. Leah, you're muted.
Now I'd like to invite Dr. Rukmini K, President, IAP Trivandrum District Branch, for the felicitation.
Good morning. Good morning, everybody. Our expected National President, Dr. Ramesh Kumar sir, IAP Kerala President, Dr. Vijay Kumar, Secretary, Dr. Johnny Sebastian, my respected teacher, Lalitha Kailas Madam, our Secretary, Dr. CB, and National Executive Board Member, Dr. Riaz, and all the seniors and my dear friends. It's a real honor for me to come here in this platform and give a felicitation for a best CME in Kerala, I'll say. Because previously I used to attend all the IJPP CMEs because it will be very crisp, 45 minutes for one topic, and it is finished, and whatever a general practitioner should know, it will be covered in 45 minutes. That was the best part for IJPP CMEs. And just like that, now for the last 8 years, we are having this CME at Gokulam, which is also in the same pattern and is very good for the general practitioners. So now instead of IJPP, I would like to attend Gokulam CMEs rather. And that's the best part of this Gokulam CME. And now it has come to our own land, our own Kerala. The other one we will have to go and attend at Chennai. So that's the difference. And for the last 8 years, it's going on very well under the leadership of Lalita Madam and the other organizing team. And Gokulam Medical College, among the private medical colleges in Kerala, has been shown that it has a very good academic performance for the last few years. I have been to examiner to Gokulam Medical College, and I know that standard of the students there. So I appreciate them very much. And it's only because of the academics which is conducted there under the leadership of Lalita Madam, Kobina Sir, and Dr. Shaji. And with these words, I am concluding. Let us go into our CME part of it, for which everybody is waiting. All the best for the team and all the best for the CME. Thank you very much.
Thank you, ma'am, for your kind words. Now I'd like to invite Dr. Sree Gokulam Philip, Secretary, IAP Trivandrum District Branch, for the vote of thanks. Over to you, sir.
Thank you. First of all, on behalf of IAP Trivandrum and Gokulam Medical College, I would like to extend our sincere thanks to our National President, Dr. Ramesh Kumar R, for finding time to inaugurate this beautiful Zoom series of another episode of Gokulam Pedicon. As you all know, being a national president is the busiest part of a pediatrician. And as you have already heard, he has very much painstakingly taken great efforts to conduct a very excellent national Pedicon. And just after that, he's again into a series of webinars and all. So on behalf of the organizing team of Gokulam and IAP Trivandrum, I extend my sincere thanks to Sree Dr. Ramesh Kumar. And next, I would like to extend thanks to IAP State President Dr. M. Vijay Kumar for those nice words, and also for participating in this session, and also for all the suggestions and excellent cooperation for the CME. Our State Secretary, Dr. Johnny Sebastian, has always been very kind and helpful to give suggestions and support to the program. So, on sincere thanks on behalf of our organizing team to Dr. Johnny Sebastian. Next, I would like to thank our SGMC Director, Dr. Manojan Sir, for giving permission for conducting this program. Without his permission, this CME would not have been a success. So, sincere thanks to Dr. Manojan Sir for your excellent cooperation, effort, and support. And on top of that, our Gokulam chairman, Mr. Gokulam Gopalan Sir, whose blessings and patronage has always been a great support and encouragement to all the academic and social activities of Sree Gokulam Medical College. Thank you, sir, for your patronage and support. Our national EB member, Dr. Riaz, as Dr. Riaz himself had mentioned, is a student of Lalita Kailash Madam, and he has always been a support for this program, and thank you, Dr. Riaz, for the support. It would not be good to say a vote of thanks to the organizing team itself, but I cannot hold myself from extending sincere thanks and congratulations to the organizing chairperson, Dr. Lalita Kailas. Dr. Lalita Kailas, madam, has been behind this program since January itself. She has painstakingly took great efforts in choosing the right speakers for the right topics, especially from national and state level, so that the normal pediatrician would get the benefit from it. Thank you, Lalita Kailas, madam. And she is now the principal of Gokulam Medical College also. Next, the HOD of the Department of Pediatrics, Dr. Gopinathan sir, who has taken great effort in conducting this program and motivating all others to participate in this. Thank you, Gopinathan sir. And the organizing secretary, Dr. Shaji, has taken great efforts along with Dr. Lalita Kailas madam to organize this event. So thank you, Dr. Shaji. And I would extend my sincere thanks to all the national and state leaders and the speakers. I'm not taking the names one by one, who have joined here to make this program a grand success, and also the speakers who has come from outside Kerala and also from inside the Kerala for participating in this great event. Last but not the least, to all the audience who have spared their time to be a part of us to attend this another great session of Gokulam CME. Our sincere thanks on behalf of Gokulam team and IAP Trivandrum to all the members who are attending here. Thank you. I wind up my words.
Thank you. Thank you, Sibi, and thank you all the participants of this inaugural program. Inadvertently, if I have left someone, sorry. A very warm welcome to all of you, Joes, and all the other senior faculty members, and all my colleagues. So I think we are moving ahead of time, but still I think we'll continue with our next session. So the next we have, is it okay, Riyaz? Shall we go ahead?
Yes, ma'am. Yes, ma'am, please.
So the next session we are going to have is a session on obesity by Dr. P.S.N. Menon, sir. Obesity, I think actually, I have allotted a thesis topic to one of our pages. Really, it is alarming. Now, how many of our children in the post-COVID era are gaining weight? So that is what actually triggered me to select a topic like this. And I talked to P.S.N. Menon sir because I know that his favorite topic is actually thyroid and thyroid related. But still, I had asked him whether are you comfortable? But he said very wholeheartedly, he supported me. He said definitely he'll do. So thank you, sir. So to carry forward the session, we have to moderate the section. We have Dr. Riyaz. I already introduced him. He's the associate professor of pediatrics, as well as the senior pediatric endocrinologist of FCT, that is the Government Medical College, Trivandrum. A person very active in IAP, that is now he is the National Executive Board member also. And above all that, I had mentioned initially as a student and later as a colleague and now as a true friend. I think it's always willing to support me and help me in always, be it official or be it personal. So I'm really happy to welcome you and also happy to invite you to carry forward the session by introducing the topic as well as the speaker. Over to you, Riyaz.
Respected teachers, seniors, and my dear friends, it's indeed a great pleasure. I would say a double pleasure here because as Madam told, it's a relationship which is there for more than 2 decades now. She has been mentoring me since the time of a house surgeon, and later made me or introduced me rather into the field of pediatric endocrinology, and it goes on. And she makes it happen such that in all of her programs, I am a part. Thank you, madam, for that. And coming to Menon sir, I would say he is like a Abel Bandhavan, like because for this TOT, it was a actually Ramesh sir was planning for multiple TOTs, and when he told there is a TOT for the whole country to be launched during the Pedicon, Sir himself was not very sure whether he could come because of the COVID situation. I think after a long gap, he is coming to India for the only purpose of chairing or conducting this TOT at Delhi, and it has launched so well. And I think his efforts are going to be carried forward all over the country under the leadership of Ramesh sir. Hats off to you, sir, for that. And I'm not sure he could he make it come to Kerala this time. I don't know he has time for that. And about his official introduction, I think all of you know him. He is currently working at Kuwait as head of department of the Armed Forces Medical College there. He has been a long-time faculty at AIMS, during which time the seeds of pediatric endocrinology was sown, and it grew into a separate subspecialty, and has pediatricians practicing the same and pursuing the interest in all over the country now. And as Madam told, Sir is the apt person to talk about any pediatric endocrine subject. And regarding the obesity pandemic, all of us are really alarmed. I would say in our pediatric diabetic clinic, usually over 1 year, we usually may find 2 or 3 cases of type 2 diabetes, new cases of type 2 diabetes. But in the last 3 months itself, that is the third month is only coming to an end, we already had 6 cases of type 2 diabetes this year. And all of those children are obese, and all of them has gained this weight during the COVID pandemic. So as pediatricians, we have to do something about this pandemic. And I welcome Sir to enrich us with your knowledge and guide us through to how to manage this pandemic in children. Over to you, sir. Thank you.
Thank you, Dr. Riaz, for a, what should I say, very beautiful introduction. I don't think I deserve all that praise. Let me go back to basics. And my duty is to guide you and my colleagues how to manage, detect, and most importantly, because nothing really is there in the treatment horizon, how to prevent an epidemic. So it was a challenge when Dr. Lalitha, with whom I had interacted several times, gave me this option. And I have been reading, and it has been a difficult topic, even in the best of the best institutions. So at the outset, let me thank Dr. Lalitha Kailas for giving me this opportunity, not only to be with my colleagues here, but also to review my knowledge and also look at my experience of managing obesity in children. Since, let me start sharing the screen now. Is it visible?
No, sir, not yet.
Is it, am I not being permitted? Probably.
Dr. Leah. Sir, actually, you are already a co-host, sir.
Co-host.
Should be able to.
Okay. You're permitted, sir. Contact.
Mini?
So sometimes in such cases, if you just log out and come back, it will be possible. and I make sure when he comes back, make him again co-host.
Meanwhile, Riaz, do you have any endocrinology clinic? Do you have any obesity clinic per se?
Actually, madam, we are seeing obesity as part of the endocrine clinic only. And now we have the service of a dietitian, madam. It is actually attached to our diabetic clinic. The NHM has provided one dietitian on every Monday. And with her help, actually, we are able to help a few children now. Because diet as well as exercise she prescribes, and now there is some difference. Among those children with type 2 diabetes, we saw out of the 6 children, I told 5 of them we were able to stop insulin as well as metformin. They are on lifestyle management only now. All got reversed actually.
Maybe little pre-adolescent and 12 years, they'll
Yes,
be able
yes.
to cooperate.
Yes.
But younger children that which we see, and frighteningly around 30 to 40% of the children had fatty liver disease also, and with a deranged liver enzymes.
Yes,
really frightening, really,
yes. Really frightening.
Yes, we also got a in last 3 months we got a 4 type 2 diabetics.
Yes, sir. The same is happening.
I told you, I had also the type 2 diabetics.
Yes, yes.
All are obese.
Yes. I think everyone now, I think we should start practicing that also. Whenever a child with obesity comes, we need to look at the blood sugars. And also maybe we may do a GCT also, because there are children who are having type 2 diabetes.
Yes, maybe you can ask sir to send the PPT to.
That is what, madam, I'm going to call him.
Good morning, Sumaran.
Good morning. What happened?
The PPT is not getting this thing.
Madam, Madam Sir told he thinks it's like a some net issue. He's trying to join back. He has asked for a link through the mail, and he told he don't mind if we go on with the next talk and later he can join.
Okay, maybe that will be better because Dr. Gauri Shankar is here,
yes,
and Dr. Sukumaran is also here. So shall we go ahead with that?
Yes, ma'am.
Okay then.
And can you ask someone to send a link through the mail?
Sir, yes, sir.
Okay.
Yes.
So our next session is on practicing pearls in pediatric pulmonology by Dr. Gauri Shankar, consultant pediatric pulmonologist, Dr. Mehta's Children's Hospital, Chennai, chaired by Dr. Ajit Krishnan, who is currently the HOD, Department of Pediatrics, Government Medical College, Trivandrum. I invite Ajit sir to introduce the speaker and the topic. Over to you, sir.
So very good morning, my respected teachers and my friends. First of all, I am very happy to chair this session of the 8th Annual CME Pediatrics 2022 at Gokulam Medical College. I am thankful to Lalita Kailas Madam, my great teacher and mentor, and Professor Gopinathan Sir, HOD of Pediatrics, Gokulam Medical College, my beloved teacher and my guide, and the team of Sree Gokulam Medical College who has conducted this CME. I am very happy to chair the session by beloved teacher at Mehta Hospital while I was doing the fellowship in pediatric intensive care, Dr. Gaudi Shankar sir, and he's actually he is most gentle pediatrician in Mehta Hospital at that time. And another person is, of course, respected Thangavelu sir, and he's not only gentle, he's a very busy practicing pulmonologist in Mehta Children's Hospital, and he is the emeritus editor of the Indian Journal of Practical Pediatrics, and he got Pediatricians Award for the state of Tamil Nadu in 2013. And he is the author of Know Your X-Ray, IJPP Series 2, and co-author of Essentials of Pediatrics Pulmonology, and associated editor to 11 pediatric textbooks, and chapter contribution to 20 other pediatric textbooks, and has many national and international publications. And we will hear from Gaudi Shankar sir regarding the practicing pearls in pulmonary pediatric pulmonology. Over to you, sir.
Thank you very much, Dr. Ajit. Is my screen visible? Am I audible?
Yes, both.
Okay. Thanks to you, Lalita Kailas Madam, mother to almost all the pediatricians probably in Kerala and from Tamil Nadu too. This is what I will say. And really heartening to see that you are doing a great job giving practical tips or inviting faculty to give practical tips to the practicing pediatrician. As Professor Thangavelu sir will say, only three things always has to be in circulation: blood, money, and knowledge. Most important is the knowledge. And thanks for inviting me to share my knowledge with all in your state and probably other states too. Thanks to you, madam. I will start. Practicing pearls in pediatric pulmonology. We know that we have EBM, evidence-based medicine. Suman will say express breast milk, but here I will say evidence-based medicine. But to add on to that, experience-based medicine. Now coming to amoxicillin and pneumonia. Many a times you will be asking, why not cephalosporin? High dose amoxicillin in 3 divided doses, 90 milligrams per kg, the treatment of choice for fully immunized patients. Amoxicillin and cephalosporin, they exhibit a time-dependent killing. What do you mean by the time-dependent killing? A drug that achieves a higher serum concentration above the minimum inhibitory concentration for the organism for a greater period of time, the more efficacious it's going to be. We know that amoxicillin has got very high favorable pharmacokinetics. What do you mean by that? Less protein binding and high bioavailability and a higher serum concentration relative to cephalosporin. No oral cephalosporin at the doses studied in children provide the same activity that equals to that of high dose amoxicillin in the lungs. Also, we have to know that second or third generation oral cephalosporin, they have adequate activity only against 60 to 70% of the current pneumonia strains, strep pneumonia strains. So you can reserve it for patients who have penicillin allergy or when the pathogen is known to be resistant to amoxicillin, like a beta-lactamase positive H. influenzae. Also, you should be very careful when you are going to give the dosage of amoxicillin to a child with pneumonia, because we know that 3 times a day dosage achieves clinical and microbiological cure in 90% of the patients. Compare it with only 65% of the patients who have clinical and microbiological cure if you're going to give it 2 times in a day. But remember that in acute otitis media, you can still give 2 times a day. Why? Because amoxicillin has got a prolonged half-life in the middle ear fluid relative to the serum. So in AOM, you can still give 2 times a day amoxicillin or amoxiclavulanic acid in AOM. Airway, is it united or it is discontinuous? Either way, we have to know about upper and lower airway, allergic rhinitis and asthma. We'll try to catch up with what is new in allergic rhinitis. The most forgotten chemical in allergic rhinitis, what we fail to use is normal saline. It is universally recommended for all ages because it reduces the symptoms and the need for pharmacotherapy. It can be used regularly or after exposure to allergen or pollutant. And among all the saline, seawater or mildly hypertonic saline are the most effective one. Antihistamines orally are only weakly effective in controlling the nasal symptoms. So it can be used for a mild allergic rhinitis. But please note that if one oral antihistamine fails to control the symptoms, there is no point in trying a different one. Patient should be switched over to something else. Now, intranasal antihistamine. The topical intranasal antihistamine, they act rapidly and they are more effective than oral antihistamine. Azilastin is good. It is safe in children. Also, olapatidine also has got good efficacy in pediatric allergic rhinitis. But the major adverse effect with azilastin is bitter taste. But olapatidine is less bitter when you are going to compare it molecule head-on. Intranasal steroids, it is more effective than H1 antihistamine and LTRA, leukotriene receptor antagonist, especially for nasal congestion. But for the efficacy to reach a maximum level, it will require several hours to days. Growth in children is a sensitive measure of corticosteroid effects. So monitoring is always important whenever you give either intranasal steroid or inhaled corticosteroid for asthma. Also, teaching the correct use of this spray, they reduce the common adverse effects such as stinging, epistaxis, and nasal irritation. And long-term intranasal steroid usage does not damage the nasal mucosa. Allergen-specific immunotherapy is slowly catching up. It can lead to symptom reduction and less need for medication, not only during the period when it is being administered, but also at least for 2 years after you stop the medication. Now coming to asthma, acute flare-up and long-term. We know that in emergency room, we give inhaled short-acting beta-2 agonists. We give salbutamol by oxygen every 20 minutes, 3 times, and then reassess. The dosage of salbutamol, many a times we try to break our head by giving 0.15 milligram per kg, trying to get the exact amount. The PG almost gets into a problem to take the proper dosage. But what you can do, in less than 20 kg, 2.5 milligram, that means half ml of nebulizer solution or 1 respule is sufficient. For beyond 20 kg, it is 1 ml of nebulizer solution or 2 respules. This is the dosage what you are going to use for nebulization. We know that salbutamol is a 50-50 mixture of the active R and inactive S enantiomer. In levosalbutamol has got only the active enantiomer, but evidence does not support its superiority. Also, this does not come under the like price control mechanism, so it is costly. Treatment always does not end in writing orders. Just look at this, what is happening here. You see, this child is getting a nebulization. Look at the nebulizer tube. It is like my life. You look at how many knots, how many U-turns, and how many wrenches. So whenever you ask for a nebulization, don't stop with the orders, but also look at how it is being given. In COVID pandemic, the spacers became the hero. But the technique of spacer usage in a child with respiratory distress, it makes one's heart to go in for distress because they do it with improper technique, which makes our training meaningless. So in emergency room, use a nebulizer because you have oxygen that will be helpful for a child who is in distress. In office practice, use a spacer. Steroids, we know that it will take about 4 to 8 hours after you give one dose of steroid whenever you give steroids for acute asthma. But we do have literature saying that for mild acute exacerbation, it is not routinely indicated. It may be prescribed based on the underlying control and previous history. When the child comes with a distress, we may not have much time in the emergency room, but to treat, whether you want to give or not, whether we should follow what the Western literature say, that is only for mild acute. For moderate and severe, they say, yes, you need to give. So even for mild, if you want to use, I don't think you should hesitate to use. You have to use it. And oral and parenteral steroid have the same efficacy. It can be given for 3 to 7 days. Also for dose of prednisolone, this is the easiest one, less than 2 years, 10 milligram, 2 to 5 years, 20 milligram, and above 5 years, 30 to 40 milligram. Because as Dr. Riaz also was discussing, obesity has become has come out in an epidemic proportion during this COVID pandemic. So if you're going to give milligram per milligram per kg, you are going to end up with a lot of steroid. So use this. These are all approved doses. Also, if you want to give methylprednisolone, it is only 1 to 2 milligram per kg. Don't use 30 to 40 milligram. It is 1 to 2 milligram per kg. Switch to oral whenever the child improves. But this is a long forgotten drug, but the advantage of dexamethasone, it's a long-acting corticosteroid. Why? Because the half-life is 36 to 72 hours. You can use it in the dosage of 0.15 to 0.3 milligram per kg. The maximum dosage, it ranges from 10 to 16 milligram. I will say maximum is 10 milligram every day for 2 days. But a single dose administration itself is more than sufficient in many a condition, in many a like problem, like when you have an acute asthma and you have a greater adherence too. We always write the correct prescription when we are dealing with long-term treatment of asthma, but look at all these. These are things which happen when we don't train them properly. Look at this child. The child is just doing a very fast breathing, not a tidal breathing. And look at this mother, how she is giving. Even though given the having a spacer, child does not want, so I give it like this. And homemade spacer is welcome, but not like this. You have lot of gap both above and below. It is not a tight fitting and it is going to injure the child's face. So whenever you are using a spacer, make sure you do it properly. And always adolescent girls needs to be trained properly. Otherwise, they will have only a fast breathing. They'll try to finish off everything fast and go out and play. So what is the correct way? Is there any correct way? Yes, if you have a valve spacer, kindly look at the movement of the valve. Find out if the valves are opening and closing even before you actuate the inhaler. Make sure the valves open and close during each inspiratory movement and expiratory movement. And then you actuate and then allow them to have 5 breaths or 10 breaths based on the volume of the spacer you use. More treatment, more emphasis is on the MART therapy. I'm sorry, I don't know why the slides are jumping, but sorry for that. More emphasis is on inhaled steroid with LABA. This is by GINA, even for like 6 years onwards. They think that parents, they are not compliant with the therapy. But most of the practitioners know when the doctor, primary pediatrician says something to the parent, they follow it to the rule book. And whether we need to add on one more drug to inhale corticosteroid, I really don't have an answer because I still use only inhaled corticosteroid. I don't use the combination for children less than 11 years. And even for about 11 years, I'm able to have a good control with a single drug if the technique is proper. Congenital airway anomaly. Look at how this child is breathing and failing to thrive. See, this is a problem with laryngomalacia. How can you improve the quality of life? How can you improve the weight of the child? Can you reduce the symptoms to some extent? Yes, you can definitely do it. How? This is what I have been following. Domperidone, 0.15 milligram per kg, 8th hourly for 6 weeks to 8 weeks. 8th hourly means I always write the timing also. 6 a.m., 2 p.m. and 10 p.m. Like, because if you give them 8th hourly, you give the timing, they do settle down well. Because laryngomalacia, GERD is often associated with laryngomalacia. This is the literature from Pediatric Respiratory Review, where 65 to 100% of infants with laryngomalacia have reflux disease. So you give domperidone, you are able to reduce the associated GERD and you are able to make their life better. Oxygen and bronchiolitis, another controversial topic. Weaning oxygen in bronchiolitis, when you are going to wean, when SpO2 is 94 or 92 or 90%. Because the threshold for oxygen discontinuation, it represents one of the main determinants influencing the discharge from hospital. More than 90% oxygen threshold has been recommended by Finnish and 2014 AAP guideline. In 2015, NICE guidelines say SpO2 above 92% patient discharge, you can discharge the patient. Recent studies says that oxygen discontinuation when SpO2 is above 90% is safe and is associated with improved outcome. Don't look at only one number, you look at the child as a whole. Your lab parameters and your saturation is only something like a traffic light. And always don't look at the traffic light always. You have to look at the road to drive safely. If the child is otherwise doing well, if the child's saturation is above 90, you can discharge but follow them up properly. TB. You know that in 2021, this is what our WHO Director General said, world is committed to end TB by 2020. Improving prevention is the key to making this happen. So what happened in July 2021? Our government gave the TB preventive treatment in India. Why they were talking more about TB preventive treatment to contacts? The risk for TB disease after infection is increased more than 25 times in contacts of bacteriologically confirmed TB patients compared to the general population. Also, a contact of patient with active TB, if they are going to develop TB disease, 75% develop within 1 year of TB diagnosis of index patient and 97% within the 2 years of TB diagnosis of index TB patient. And mantle positive in less than 5 years old to treat or not to treat. Pediatrician is not going to order TST for every child who comes to them for treatment. If a child is less than 5 years old, if the child has got a mantle positive, give them TB preventive treatment. There is no need to give pyridoxine unless the child is severely, acutely malnourished. Whether we need to consider mantle positive for TB treatment, preventive treatment in 5 years or 6 years, less than 5 years or less than 6 years. Nowadays, only contact positive, yes, you give treatment after ruling out infection, after ruling out TB disease. But if the mantle is alone positive in less than 5 years or less than 6 years, always treat them, but screen all family members. This is not given in the guideline. You do a mantle for something else. Child has got a cough, child has got recurrent episodes of fever. You are not able to make out what is happening. And then finally you order a mantle, it becomes positive. Then you give them treatment. Make sure you screen all the family members, which is not given in the guideline. It is our duty to eliminate TB from India. So when you're doing a test for a child who is unwell and if the mantle is positive and you treat the child with 6 months of INH, but screen all the family members. How do you treat a contact? 6 months of daily isoniazid monotherapy. Less than 10 years, 10 milligram per kg. More than 10 years, you give them 5 milligram per kg. Maximum is 300 milligram. Instead of monotherapy with INH, this is the government advice to give weekly rifampicin plus isoniazid. Weekly once for 3 months, that means only 12 doses. So it saves a lot of time and energy for government and the community as well. But till now, it has not come into practice, it will come in shortly. Preventive therapy for household contact of MDR-TB. In every conference, this is a common question. They say, don't give anything, but now things have changed. What is it? In those with MDR-TB, but if they are going to be fluoroquine sensitive, confirmed pulmonary index TB patients, if the adult contact is fluoroquine sensitive, give 6 months of levofloxacin to the child, 15 to 20 milligram per kg per day. Suppose if the child has got INH resistant but rifampicin sensitive, your life is going to be very easy because you are going to give only 4 months of rifampicin for the contacts. If the child has got a rifampicin resistance but INH sensitive, very easy, you give them 6 months of INH. So I don't think you have any doubts when you're going to have a child who is a contact of MDR-TB patient. And to detect TB infection, government now says, previous guidelines say don't use IgRA, interferon gamma release assay, but now government says, yes, you can use IgRA. To IgRA, quantiferon and T-spot TB assay. The antigen used are early secretory antigenic target 6 and culture filtrate protein 10. But the IGRAs have to be performed with positive and negative controls. In the report itself, they will have positive control and negative control too in each of the IGRA results. But this is the literature from Pediatrics in 2021 December. The test for detecting TB infection from American Academy of Pediatrics, they say 2 available but imperfect methods. They don't distinguish TB disease from a TB infection. So what are the two available imperfect methods? One is tuberculin skin test and another one is EGRAS. Then they also said suboptimal performance in immunocompromised patients who are at greatest risk for progression to TB disease. So these are the takes from AAP as late as December 2021. And in terms of accuracy, whether you are going to use a quantiferon test or T-spot TB test, none of them is superior over other. And they are also susceptible to test and retest variability due to manufacturing issues, due to sample collection issues. Just because the name said quantiferon gold, it does not mean it is a gold standard test. It is a superior form of our tuberculin skin test, that is all. And what is the AAP advice? Tuberculin skin test is preferred in children younger than 2 years. IGRA is preferred in children 2 years or older, especially if they are BCG vaccinated. And what does the latest WHO guideline, like it is not a guideline, it is a recommendation given to the countries, like in November 2021, the WHO has recently added an alternative sample. What is the sample? It is the stool sample in addition to respiratory tract samples for diagnosing pediatric tuberculosis. But they have also said there is a higher frequency of invalid test results from stool sample compared to gastric aspirate. So they always want a standardized stool sample preparation protocol before it can be adopted for pediatric TB diagnosis, but we are going to have an easier time in getting a sample for TB diagnosis instead of trying our best to get a gastric sample or induced sputum. Stool is a sample which can be used for TB diagnosis with our cartridge-based nucleic acid amplification test, that is your GeneXpert or GeneXpert Ultra. This is the latest probably update or probably the missile from ICMR. This is a busy slide. I want you to focus on only this. Do not do a TST or Manto test. And don't start ATT based on TSP positive for those with pediatric intrathoracic tuberculosis. And they have said for pediatric lymph node TB, they again want to microbiological diagnosis, send for nucleic acid amplification test and smear for AFB. And it is not essential to have a lymph node cytopathology. That means FNAC cytopathology. In adults with pleural effusion, this is the flow chart what they have given. Pleural fluid ADA can be done, and if it is less than 40, do a biopsy. If it is above 40, you can initiate an empiric anti-TB therapy. This is in adults, but this is not given in pediatrics. They said in pediatrics, don't do ADA because they say they don't have the cutoff value. Steep TB with hypoxia and endobronchial TB. This is the statement from ICMR. But in miliary TB and in endobronchial TB, you need to give steroids to save life. The intrathoracic TB, they say do not do Manto or TSP or IGRA. But if we are not able to get a tissue sample, if we don't get bronchoscopic aspiration, lymph node aspiration, If only the manto is positive, if the size of the lymph node is large, and if they don't have any other reason for the lymph node, intrathoracic lymph node, if the blood smear is normal, we are not going to miss out any malignancy. Means you need to give them ATT based on even a manto positive. Lymph node TB, if the aspirate is very minimal, how to do a CB-NAT? Here, you have to dilute it with normal saline up to 2 ml, and you can send the sample for CB-NAT. You know, whoever has been doing FNAC will know how difficult it is and how much quantity you will get from a lymph node aspirate. If it is not a pus, you will get around 0.1 ml. If you send it to CB-NAT, they will say insufficient sample. So dilute it with 2 ml normal saline and send it. Do not do ADA in pleural effusion. The same government says you can do ADA in adult pleural effusion and give treatment. So you can do ADA in pediatrics. Any cutoff above 40, as like till now, anything above 40, you can take it as suggestive of tuberculosis. If the smear of ascitic fluid is negative, or if CB-NAT of ascitic fluid is negative, what to do? You go by the symptomatology and you be a clinician, and you can start ATT based on clinically diagnosed tuberculosis. They say no steroids in abdominal TB. If there is going to be serositis in tuberculosis, any serosa is involved, there is a role for steroids that we need to understand. Smear examination at the end of the treatment. Even in the beginning, we are not able to get a smear positive. Then where will you get the smear, and where will you have a positive outcome or a negative outcome at the end of the treatment? Always it is something like they give a ready-made dress and ask the pediatricians to fit that into our constitution. Many times it is difficult. These are all the difficulties which we are going to face, and these are the possible ways in which you can outsmart the difficulties. So this is the last slide. Everyone improves their clinical skill as they age. Not all children come with textbook-like description of illness to make diagnosis easily or to manage easily. Guidelines always think that one size fits all, but one size does not fit all. Experience-based medicine has value. Kindly respect it. Real teachers teach us from their books, not from their books, but from their heart. My greetings to all my teachers, and thanks for giving me an opportunity. Thank you.
Thank you, sir. Thank you, sir, for your updates for the practicing pediatricians, and it was very much useful for the practicing pediatricians. I think there are a lot of questions.
You can give 2 questions. The rest, I think Dr. Gauri can answer in the chat box. You take 2 questions.
Yes.
Okay. One question is, what is the dose of intranasal antihistamines? Age and dose of intranasal antihistamines.
Thing is, the latest guideline from European Union, they say 1 squirt. It is not milligrams. It is 1 squirt of the antihistamine, whether it is olapatadine or whether it is the other one. But here we have only olapatadine that you can use, or azilastine. Many times azilastine comes with a combination of intranasal corticosteroid. But European Union has got a azilastine intranasal spray. They use that. They don't go by the dosage. They always go by 1 squirt in each nostril.
Sir, another question is, if using Respule, does it need to be diluted with normal saline?
If it is going to be only 1 Respule, it is going to be 2.5 ml. This will be insufficient for nebulization. You need a minimum of 3 ml. So you need to add normal saline to 3 ml.
Okay, sir. There are many other questions, Elsat madam. There are many other questions. So there is no time for questions. So we'll go.
Okay.
Thank you for your talk, sir. Thank you, sir.
You can answer in the chat box. Thank you. Thank you, Dr. Gauri Shankar, for that excellent and extremely useful session, for giving us the real pearls of wisdom to share with all our audience. Just one comment from my side. There is in Kerala, we are way ahead in the management of the latent TB infection. We have started almost 1 year back with the 3 months INH rifampicin HR regimen, but not the 6 months. And for adults also, they have started with the rifampicin. But for children, as of now, we are only 3 HR, and we have the government is applying free of cost a RIGRA. So above the age of 5 years, we are doing a test and treat. This is only a comment. Kerala.
Probably Kerala leads the way. We have to follow, but we are very slow, ma'am. Thank you.
Okay. No, this is just for information. Thank you. I think we shall move ahead with the, and I think I can see PS and Menon sir back. Over to you, Riaz and Menon sir. Thank you, Gaurish.
Thank you, ma'am. Sorry for the inconvenience caused. Menon sir has joined back. Without delaying much, I am inviting sir for starting his talk. Menon sir.
Just give me a minute.
Yes, sir. Yes, sir.
Give me a minute.
Okay, sir.
Meanwhile, maybe Dr. Gauri Shankar can answer some questions. Like, what is the preferred dose of deflazacort? Elizabeth had asked.
Madam, I don't use deflazacort because it is costly. I don't have the milligram per kg. I'm really sorry. I need to look at my book, madam, because being worked in government for about 18 years, price.
Okay, that's all of us.
That's why, madam. And MAR therapy, they said how many doses? Maximum of 12 doses we can give, because the cap on formoterol is only 72 micrograms. And so we cannot go beyond that. We can use 2 to 4 puffs, maximum of 3 times. If the child needs much more than that, you cannot give the same at home.
Okay, thank you.
Okay.
So the slides are visible, sir.
Okay. Thank you. That's nice to know.
But not in the.
Can it change to the PowerPoint mode, sir?
Yeah.
Okay.
Is it visible?
Yes, sir.
Yeah.
Perfect.
Am I audible?
Yes,
Yeah.
sir.
Sorry for this inconvenience. Out of place, traveling, lot of problems. Net and everything. Once again, thank you for your patience. So to save time, I will just start going through the slides. When Dr. Lalitha Kailash asked me to talk about childhood obesity, and that is a ticking bomb, I got thinking whether it is really a ticking bomb, and started looking into literature, what is happening over the period of time. What I found is that if you go through the reviews on pediatric obesity, and most of it, mind you, are not in pediatric endocrinology. It comes under the field of pediatric nutrition, lifestyle, environmental medicine, and you won't find much in pediatric endocrinology. It is now labeled as a new age epidemic. And it is now the #1 global lifestyle disorder. We thought it was a disease of the affluent and the developed world, but actually now China which is not really considered to be the affluent or the developed, is the number one largest number of obese children in the world, followed by India. As we learn more about what is causing obesity, whether it is nutrition alone, we find that literature is flooding with knowledge on epigenetics, a lot of hormones which we never knew about, what we are calling as energy regulatory hormones. And we are learning more about newer and newer pathways in which the currently known hormones are functioning to in the genesis of obesity. And I especially look for whether COVID-19 is really responsible for increasing this epidemic in this country and elsewhere. And we have literature not far, but as near as from Indonesia, along with other European countries, which show that there is something going on with COVID-19 and obesity. So with that background, let us look what is the epidemiology of obesity now. So obviously, whatever data that we have is of the pre-COVID-19 era. According to that, if you use the guideline or definitions of the International Obesity Task Force given in 2013, nearly 25% of all children and adolescents, that is 1/4 of the children, have obesity or overweight. Then we thought that with our interventions, it is plateauing, at least in the developed world. No, it has not happened. Really, plateau is only a statistical miscalculation. There is increase, especially of obesity, of the severe forms, that is more than the 97% or even the 120%, that it has gone up from 0.3 to 4.6% in the children below 12 years of age and above 5. And from 1%, it has gone up to 9% in adolescents in USA, where you have data for every annual growth data available now. We have currently the new data from the National Family Health Survey, 5 available. And also we have data from the Comprehensive National Nutrition Survey conducted in 2019. According to that, in India, 20% of children have obesity or overweight. And obesity and overweight calculated as not by the standard definition, but using the criteria that is what is called weight for height being more than 2 standard deviations, is 3.4% in around under 5, and around in 5 to 9, it is around 4%. So it is probably a less calculation, or probably it's a skewed calculation data that has happened in the population that is surveyed. But if you look at the overall data, that we find that roughly boys, girls, it is somewhere between 20 to 25% of the population, even in India, are affected by obesity. So with this background, let me limit my talk to these 6 factors. Define what are the risk factors, speak about a bit about clinical features that help in diagnosis, what investigations we could do, how best we can manage, and more importantly, how we can prevent. Definition. For general pediatricians and general practitioners have always been considering obesity with weight. And we are telling as pediatricians and pediatric teachers, it is not weight, it is increased body fat. I would like to stress here, it is not just body fat alone. What we are concerned is about the accumulation of central or the visceral fat. Unfortunately, there are no conventional, easy to use standard methods to assess body composition for diagnosis of obesity in children. The so-called equipment, which are very cumbersome, are not available in most medical colleges or research institutions, but luckily they are all available in the conventional competitive weight management commercial centers, but not in your medical institutions. So we have to go by simpler definitions, that is body mass index, the conventional formula. But you have to realize that using body mass index has its own problem. It does not differentiate the fat mass from the lean mass. A person can be highly exercising, can have muscular hypertrophy, and may have actually wrongly diagnosed have obesity because of that. There could be other reasons. The children could have other metabolic and skeletal-muscular diseases which can interpret the values wrongly. And body mass index, by all means, is a very poor marker of the most important complication of obesity in children, that is metabolic syndrome. So why not waist circumference? Why not waist hip ratio? These have been studied in children in very few cases. So we have not really standardized nomograms for these for use in children. Till such standards come, we have to use body mass index. There are different criteria using different definitions. So you can go, depending upon your research study, you can use anything. But it is much easier to use our own IAP growth standards. And then our growth standards can give you anything between 5 to 18 years. We can say that anybody with a age and gender-wise cutoff for BMI more than 23 kilogram per meter square is considered to be overweight. And those about 27 kilogram per meter square is also considered to be obesity. Now, why these criteria have been made is because they have looked at the general body build of the Asian population, and they have come to a conclusion that 71 to 95th percentiles is equivalent to 23, whereas the 90 and 90 percentiles come around to 27 kilograms. You have to remember that the criteria which is put up by WHO are based on a data from NCHS almost 50 years back. And they are the only ones which are giving clear data for those who are below 5 years. So it is an age-old data. It is not probably accurate for current century, current years. So till we get better standards, we have to use the IAP growth standards as our criteria for diagnosis. Luckily, my colleague, Dr. Vaman,
Sir, your audio is muted, sir.
Am I audible now?
Yes,
Yeah, it's okay now.
Yes,
Yeah.
yes. Now it is audible.
Yeah, it's automatically coming as mute. Sorry, you have actually at the moment growth charts available at your website. Very easy to calculate. And also, all of you can easily see whether it is appropriate, the growth and development is appropriate for your target centiles. Also, you can see using a pocket edition. You can actually quickly screen at your OPD. You can find whether the children are on the higher trajectory of growth for weight and gain, especially for the body mass. So these are available at our pocket tips. And I think most pediatricians are now using, I find that they are using these mobile-based tools for diagnosis, but these are not accurate below the age of 5 years at the moment. They are good, but you have to really clinically evaluate and observe for a period of 3 months and see whether the values remain stable. So that much about estimating and diagnosing. Then when it comes to obesity, the cause, simplicity makes pediatrician to divide them into various groups. So we have been using simple obesity and non-simple obesity, constitutional obesity and pathological obesity, exogenous obesity versus endogenous obesity, nutritional versus not nutritional. But when I look through the literature, I find that what one expert means by one term is different from what the second author says. So it is very important to clearly look at the definition given by each study, each guideline about what is constitutional, what is pathological. Pathological is one condition in which you can pinpoint a cause, as far as I am concerned. It could be an abnormality in the hormone. It could be secondary to a syndrome. It could be a single gene or a multi-gene disorder in which you can pinpoint the abnormality as a point mutation or other abnormality in the chromosome or genetic material. When nothing is available, they all come considered as probably they are not simple, they are undiagnosed forms of obesity. We generally believe that it is due to energy disbalance. That is, there is a difference between the energy intake and energy consumed. But very rarely pediatricians or nutritionists really find out what is that disbalance which produces this obesity. So when you look at textbooks, including the recent textbooks on pediatric endocrinology, you can say that you can easily find listings of pathological causes of obesity. You can see monogenic disorders in which abnormalities of the genes for leptin or its receptor, or melanocortin, which is considered to be the real pathway for mediating satiety and obesity, or its receptors for 3 and 4, or its mediators, melanocortin, or several enzyme which helps in the activity of these, we have been found. But fortunately or unfortunately, the total number of cases detected to have these abnormalities are very few, and they come from advanced genetic research centers. So if I start evaluating common cause of obesity in probably Trivandrum, I may not even find a single case of these abnormalities. These are more common with a strong family history and also with a genetic background. It is very common to pinpoint hypothyroidism, Cushing syndrome, which they have telltale evidence, for example, a child. But generally, you can pick them up much earlier with a growth chart screening. You may be able to pick up children who have been missed out in the newborn screening. A child with very early stage of Cushing syndrome, you may pick up. But if you ask me in how many children with obesity that I have seen have probably associated primary endocrine disorders, it would come to around less than 5%. It is mostly comes because they have not been diagnosed early enough. It is much more common to find probably abnormal syndromes. There are a large number of syndromes. Smith and et al. Gives probably almost around a number of 150 syndromes with obesity, but pediatricians and pediatric endocrinologists and pulmonologists are more happy with detecting and diagnosing Prader-Willi and sometimes other conditions like Bardet-Biedl or Armstrong. Other conditions are very, very rare. These conditions all have telltale clinical features. So it is impossible to miss the diagnosis, and obesity is always associated with a specific dysmorphic feature or a stigma of the disease. So the question comes, what do you do when you do not have any clinical clue for these conditions? Then we go back to our original hypothesis that it is probably a host versus environment. Here, what we speak about genetics is not about point mutations or genes. That is about the genetic background of the host, which is responsible for the ethnic background of the child, where he is coming from a background which is likely to have obesity. Now, the pediatricians are all concerned about the first 1,000 days, which includes the pregnancy. And we now are concerned about the early childhood development EDC programs, even initiated by the WHO, endorsed by our government of India too, which consists of marking the features of obesity right from conception itself. That means antenatal care, picking up whether the mother is picking up undue gain in weight, or whether there is something which is affecting the fetal programming enunciated by Barker, Is there something in the pre-pregnancy nutrition that modifies the development of the organs of the body, which prevents them from normal development and induce a metabolic abnormal milieu? Also, it is important to see when you evaluate a child, whether what you are going to do. In the first level, probably we will do a family history and individual history. Second level, we will do a clinical feature and metabolic evaluation and potential factor. And third level, we will look at whether the clinical evaluation of the disease. In the history, as I told you, we will look actually at detailed antenatal history, including that of pregnancy, childbirth, postnatal period, just not about birth weight, but about whatever abnormal pregnancy factors were there during the antenatal period. The most important tool in your hands is the growth records. This will help you to pick up the onset of weight gain and also probably the factors that stimulated this particular gain. One-time record is never a diagnostic. You have to go through progression of the weight and height gain, at least for a period of 3 months. We say at least 6 months for height gain or height loss. You have to all look for associated features of obesity or a complication thereby. It is important. You cannot differentiate or separate developmental history from obesity and weight gain. It is important to take a total feeding history, not current, but also in the past, family history of obesity and other associated comorbidities in the family, what lifestyle the child is following, including not just activity, hyperactivity, exercise, but also when there is no activity, as in sleep, whether there are mental health issues in children, for example, that is leading them to eat more. There could be medication. I think in our society in Kuwait, actually, a lot of medication is used for respiratory disorders and undue use of steroids, and also anti-epilepsy medications are now being used as obesogenic. So also important to look for common. So what are the lead alerts which helps you for history? That will be early onset before the age of 6 months, rapid progression. If there is child has developmental delay or seizures with obesity, if he has got a neurodevelopmental deficit, there is unexplained hypotonia or feeding difficulties, the child has polyphagy or insomnia, and increased appetite with the CNS symptomatology, I would go for early evaluation in this particular child. When it comes to examination, all growth anthropometry is important, just not weight, height, BMI. You have to also start doing waist circumference. Let us start doing it. Let us start calculating waist hip ratio. Let us look at the fat distribution in general. Let us make it a habit. Then probably we'll detect abnormalities more common. It is important that every child with obesity should have his or her blood pressure recorded and staged according to standard nomograms for age and gender. Every child should be evaluated nude for sexual maturity rating. It is quite common to come for complaints of short undescended testes. It is also important to look for breast development, whether it's a true gynecomastia or lipomastia. Should look for clinical evidences for insulin resistance, which could be in the form of skin tags. It could be a skin acanthosis nigricans. It could be evidence in the form of hirsutism on some parts of the body, mostly on the face, chin, and on the extremities. And yes, androgen excess can be associated with a child who is growing tall as well as obese, can manifest as acne and hirsutism. It's important to look for metabolic syndrome with hepatomegaly and also look for dysmorphic features. So what are the red alerts when you look for examination? Number one, discordance in growth. That this child has got a height which is less, but the weight is going on the height. Then you have to look at the body mass index and see whether he is above the 23rd or the 27th percentile. Any abnormality in puberty would be a alert for a possible endocrine disorder. An associated disorder will be a good one for a child who has got a problem with dysmorph features for genetic abnormality. Pushing out features, a presence of the AHO, that is pseudo-hypoparathyroidism habitus, or Santil asthma, as you can see, white patches and nodules on the eyelids, all suggest a syndromic or systemic obesity. So once you have done and you have suspected that the child could have a associated systemic reason for developing obesity, what investigations can be done? In my practice of over 40 years, I cannot say that there is a standard protocol for investigating obesity. It is always dependent on the clinical features and history. Should we do routinely CBC, blood biochemistry just like that? No, I don't think it does not help you. Sometimes it only misleads you. The first thing that I would do probably would be to do a fasting blood glucose, and if not possible to do an OGTT, I will do a 2-hour postprandial. That is probably to help me to differentiate, is this child not obese? It is to just detect me, is the child has a tendency for pre-diabetes, and then more strict with diet instructions. It's important to do a baseline LFT in every child because that would be the forerunner for the development of non-alcoholic fatty liver disease, which now I think many experts are now relabeling as metabolic fatty liver disease. But the criteria used for children varies for different ones. My lab uses any child with an ALT level more than 25 or 23 in boys and girls as abnormal in the first setup, but does not call for abnormality. If repeat evaluations show that it is rising above 50 in boys and more than 44 in girls, it is suggestive that they are probably leading to NAFLD. Should we do routinely all cholesterol profiles in children? Not necessary, but if there is evidence suggests that there is more tendency for obesity and also non-nutritional, then definitely it is important. I would say that most important is not total cholesterol, but non-HDL cholesterol. The other investigation that I find useful, especially if there is a disparity in height as well as weight, is a bone age. It is common in routine practice to find an advancement of bone age in almost all children with obesity. So anybody with an advanced bone age of more than 1 year, then you would think of probably other abnormal endocrine causes. Anybody with a delayed bone age, again more than 1 year of the less than 1 year of the chronological age, should also need investigation. Should we do a thyroid function test? Should we do just a TSH? Should we do just a T4 alone? Should we must do a total or a free T4? It is known that even in normal obese children, there is a profile of subclinical hypothyroidism manifesting as increased TSH levels, not usually above a level of 10 milli-international units per liter. This is a physiological phenomena initiated by the leptin in order to increase the activity of the child, metabolic activity of the child. So now, normally, these children with a raised TSH will have a near normal or slightly elevated T4 or free T4 levels. It is also common to find sometimes with this TSH level a little elevated free T3 levels. So you have to actually evaluate for thyroid function by follow-up and also not by TSH levels alone, but also by the free hormone levels. We are concerned about diabetes. So should we do insulin levels to detect insulin sensitivity? Should we do routinely HbA1c? In general, they are not helpful in management. If you have acanthosis nigricans, You don't gain anything by doing an insulin level, either fasting or coupled with the glucose, all insulin under the curve. There is none of these things really help. Whether you do other hormonal tests depending upon whether there is a clinical associated abnormality. Testing for calcium, phosphorus, alkaline phosphatase, routine vitamin D is generally not helpful unless there is an associated skeletal abnormality. We don't gain by routinely doing a MRI brain in the absence of a CNR involvement. Should we do a fibroscan of the liver to find out NAFLD? Again, no. It should be done only if you have screening criteria positive for NAFLD. Should we do routine echocardiography? No. Again, it is useful only for follow-up. You should do polysomnography if there is an associated sleep disorder or you are suspecting Prader-Willi syndrome. Genetic studies, it is mostly a research tool. For none of the genetic conditions, we have actually a specific treatment. So it is essentially to guide the family about further management and disease that you have to do these tests. So choose your test wisely. There is no one answer in the test that will help you in diagnosis. Also, it is important when you interpret these hormones, especially the lipid profile, it is important that you should not be considering just the values provided by the lab and by the normals provided by the lab. You should fall by standardized guidelines, whether it is provided by the NICE or by the National Institute of Health. It is very important to fall. And I must tell you, please calculate the non-HDL cholesterol also. A lot of complications occurs. I think all of you are aware. I won't like to bore you with listing these conditions, but a good clinical examination especially should rule out associated musculoskeletal. A lot of abnormalities can be there incidentally. So the main worry about developing obesity and in childhood is actually its tracking into adulthood and creating more problems which are more morbid conditions. Most important about this is metabolic syndrome, which is characterized by central obesity, hypertension, dyslipidemia, insulin resistance, and impaired glucose tolerance. Why? It is tracking into adult, and then it can produce coronary artery disease, stroke, and type 2 diabetes mellitus. What happens in this condition is that the adipocytes hypertrophy and then lead on to insulin resistance, which produce hypolysis, which affects the triglycerides, which increases the uptake of the free fatty acids, conversion into VLDL, which they later change into other forms of the intermediate density lipoprotein and small labeled LDL pectin, which are truly the ones which produces the atherogenesis. A lot of studies are going on about inflammatory markers and adenopectin, but there is no conclusive evidence except that they assist in development of the metabolic syndrome. It is very, very common only in adults, less common in children, less below 10 years. Very common if there is a strong family history and if you have other additional environmental factors responsible for that. We know that metabolic syndrome is a common accompaniment in the years to come in those children who are born with low birth weight and some of them who did not have good catch-up growth in early childhood. So it is very important to evaluate for children for metabolic syndrome. Again, the criteria used for diagnosing metabolic syndrome vary from that is used in adults. These are all available in all standard textbooks. So once you have made a diagnosis of obesity, which by itself is not a diagnostic label, and you have excluded most common endocrine, genetic, and syndromic causes, we are left with managing obesity and preventing it. It is much easier to prevent than to manage. It can be done mostly by doing a correction of the environment, improvement in the nutrition by promoting intake of healthy foods, promoting healthy activity, weight management, and more importantly, now we are actually looking at preconception and pregnancy care, early childhood diet, for example, continued breastfeeding up to the age of even 18 to 24 months, a very appropriate introduction of complementary feeding, and advising the mothers and the caregivers about what is the correct nutrition package to be used. These are easy said than done. Most pediatricians find it difficult to spend enough time in their practice counseling children and their family about nutrition. So ideally, I would use the help of an assistant in the form of a nutritionist or an expert in physical and lifestyle to counsel the family along with us in this particular program. The American medical associations have found that whether the counseling that we do are really useful or not, whether the parents and the children do follow all these things and how sincerely. When it comes to measuring height and then following up with managing BMI and BC is generally easier to do. So they generally has got a better follow-up. But if when it comes to asking children to engage in an activity which is lasting for 60 minutes, then we find that that rating requires real convincing for the family and make sure that facilities are available for that. So similarly, you cannot easily tell children not to take sweetened beverages, fruit drinks, because they are easily available. They are considered to be fashion. They are sports drinks. They are the things that children look forward to. It's not easy to change the habit. It requires continued counseling. So one visit, 2 visits do not really help to change the attitude either of the child or of the family or the caregivers. It is easy to say all these things that you have to have a planned, balanced diet. I have failed miserably in doing this. So now I follow is use the whatever is available to the family, but make adjustment to make sure that there is enough proteins and enough fats with less of carbohydrates. That is a practice that I would follow. But I would encourage for small children breastfeeding, complementary feeding at appropriate time, right introduction of cows or other milk at a later. Tell children and families that what are good and what are not so good. If you tell them do not eat, that itself becomes a stimulus. It is easier to say fiber intake, but you have to tell them what is best, easily acceptable, tasteful fiber that is available to you. And you have to find alternatives for sugar sweetened beverages. Similarly, in lifestyle, it is easy to say exercise, but exercise for how much, how long, what is vigorous, what is light exercise, this has to be shown by examples. What we now know is that with the current epidemic, we have found that screen time has increased intentionally as well as non-intentionally. If a child is undergoing 6 to 8 hours continuous online classes, especially in age groups which are from 10 to 14, because exams and others, my next door neighbor's child spends 14 hours a day in the school, online classes, 4 hours a day extra after 1 hour break for tuition classes. What will you advise them? The teacher's advice is sometimes more important than the doctor's advice, especially when it comes to education. You cannot stop classes, so you have to find a intervening media by which you can reduce screen time. But especially you can reduce screen time for children, especially for the very young. More important, you can actually inculcate good sleep habits for these children. And WHO has come out with a very good program, what we call as Ending Childhood Obesity, which is called ECO program in 2014, But I find there are very few takers for this in the real, our world practice. So what is my advice? Compliance and monitoring, and don't be strict about your forced beliefs about how to manage obesity. And there are weight-related goals and age-related goals. So every child is different. You cannot put child and adult and adolescent into the same bracket and advise them for management. We are all looking for quick remedies, some medications to control obesity or weight gain. At the moment, we do not have such gold medicines. Lifestyle still is the best, but very difficult to follow. The only drug which is recommended for use in children is orlistat, which is actually an inhibitor of the gastrointestinal lipase and controls satiety and reduces appetite. It is approved for use only for children about 12 years, but it's a very unpalatable drug. Only those who have taken it knows how difficult it is, with increased flatulence, severe gastric disease, very tendency for fecal. You have to be to the washroom. You have to have a washroom next to your place for frequent visits to a toilet. So it's a very inconvenient drug to use, but sometimes we are forced to use. Metformin, which has been used as an anti-diabetic drug, was sometimes used because initial studies for metabolic syndrome used that it could be used. But case control studies have not found it useful, and I do not prescribe metformin for simple nutritional endogenous obesity. It is used if you have a child with type 2 diabetes. And it is used in some children with polycystic ovarian syndrome. But there are specific indications for its use in that particular syndrome. If you have a comorbidity, then definitely you can use ACE inhibitors to treat hypertension. Statins are induced, it can be given if there is elevated low density lipoproteins according to the standard prescriptive criteria. Of interest lately is liraglutide, which has come as a rescuer for type 2 diabetes. It is not a panacea, it is just under evaluation. The problem with this medicine is it is now available only as an injection. It is available only for obese adults above 12 years. It is also not free of side effects. It produces recurrent hypoglycemia. There are severe GI side effects like nausea and vomiting induced, and it increases the abdominal lipase, which can reverse actually the effect of obesity. And worse is that once you stop the medication, the obesity rebounds. So it is not a panacea for managing. So those who do not respond, can you think about surgery? Well, in the Middle East where I work, it is a common practice to do bariatric surgery of one sort or the other for children with obesity. And we can use adolescent weight loss surgery, but there are specific indications as to who should be having bariatric surgery. So it is not something which we routinely advise. There are different forms of bariatric surgery, but the commonest one which is practiced in children is the laparoscopic adjustable gastric banding. It is contraindicated in any child less than 14 years and also in several other conditions. And also you have to be extremely careful when prescribing it for children with Prader-Willi syndrome or any other hyperphagic conditions. Coming to the last point of my talk, has COVID-19 really increased childhood obesity? I had to literally search through literature with a microscope and a lens to see, even though there is several anecdotal reports of increased obesity, available literature says specifically about diabetes. Following 2019, Endocrine Disorders Association has shown that there is a worsening of symptoms of COVID-19. Both type 1 and type 2 diabetes has worsened. And newly diagnosed number of children with diabetes has increased, especially 30 days after the onset of the COVID-19 infection. There are increased reports of type 1 diabetes manifesting with DKA, which can be probably understood as an infection predisposing DKA. But what we have seen is that with type 1 diabetes, that with the onset of COVID-19, the supply of medication, especially insulin for hospital-based treatment patient programs and government programs has stopped because the child could not either travel to the place where it was being supplied, or the supply to local persons had stopped because of transport restrictions. That is a probable reason for the increased incidence of DKA. But looking whether there is really an incidence of obesity and whether that obesity was truly reflecting in the form of obesity associated type 2 diabetes, it is very rare. But there are several things that COVID-19 has been responsive for development of obesity. Number one, it has changed the lifestyle. The schools have closed, children are indoors, very much difficult to go outdoors, especially in urban cities. Parks are closed, gyms are closed, playgrounds are closed. There is reduced physical activity, no place to do indoor activities in their own closed spaces in small apartments and homes. Children are spending more time with the screen time because the classes, schools, exams, everything is now screen time based. With that, children have increased snacking, and whatever we say has it as a healthy practice has dwindled. So there is definitely an atmosphere and an environment for developing obesity in this particular situation. But unfortunately, whatever studies I have looked at, they have not found any endocrine or genetic cause associated with the development of obesity or type 2 diabetes with COVID-19. So to sum up, my messages are pediatric obesity is an indolent epidemic with repercussions in adulthood. We do not have gold standard. We still go with the old standard of BMI with new interpretations using growth charts. You have to really look for red flag signs during history and examination. There is no single set of battery of investigation which help you in diagnosis or management. Choose your investigations wisely. Treatment options are very conservative, very difficult to follow. There are no drugs which are actually as a panacea. Neither is bariatric surgery a final option for management. So we have nothing else but think about prevention for the management of obesity. So obesity is a bomb which is still ticking, and I think we have to work together to prevent this bomb from going on. Thank you for a patient listening.
Yes.
Yes.
Riaz, are you there?
Yes, ma'am. Yes, ma'am.
Maybe we can answer the questions in the chat box.
Yes. Actually, I think it has been a very comprehensive presentation for the primary care pediatrician, actually, because it is our responsibility to see every child for obesity. But like when you are practicing, identifying the red flag signs are important. And as Sir told, there are a very few investigations which are essential and which we should not miss. That is very, very important. I shall take a few questions in the chat box first. So one question is the vitamin D supplementation necessary in all children with obesity? Sir, can we stop the share, sir, so that all of us can see?
Yes.
He has only one question. We are running late.
Yeah. I think there is, Indian Academy of Pediatrics has come out with very standard guidelines about the use of vitamin D. I think it has been very clear guidelines. There is nothing special for obesity in that particular. The guidelines for vitamin D supplementation in the normal is the same in all children. So I will follow the same guidelines. We do not need to do, as I said, routine vitamin D estimation in children with obesity in the absence of a clinical associated problem.
Actually, there was one question from Dr. Sherman. She's actually doing a study on interventional study on obesity, actually.
Yes.
So she was asking whether how is the gluteofemoral fat different from abdominal fat?
Yes, yes. That actually there is a difference. We are understanding that collection of fat differs in different populations and also in different ethnic populations. So we do see actually for example, the Kerala profile of a normal child, especially collection of fat, is different from that from the north. And as you go from north itself, for example, if you go from mid India ranges into upper Madhya Pradesh, Delhi, and then go over to Kashmir, you can see that the upper segment, lower segment ratio of the children differs. And with that, actually, the accumulation of fat in the musculoskeletal plane changes. So there is a difference. And I think anthropologists have looked into it actually to find out whether there is a change in the ratio. But unfortunately, there is no data available for children to check whether the change in the gluteal region or in the sacrococcygeal region or the interscapular region is different from visceral fat. The studies are available only for visceral fat for children. So we do not know whether they are diagnostic, whether they can be used as a marker for intervention. But these are fresh researchers. They have to come in, they have to guide us.
Thank you, sir. And there was one question regarding reduced carbohydrate diet, because keto diet and such diets are very much in the social media and all. So what about such diets?
I didn't want to comment on this because a lot of diet, especially now, Ramadan is coming. So there will be diet will be there. So the question is dieting for 12 hours, dieting with 24 hours, alternate day dieting, intermittent dieting, all have been used to evaluate the blood sugar profile and impact on type 2 diabetes. But there are no real studies to say whether there is carbohydrate-free true keto diet or a half reduced carbohydrate diet or a carbohydrate taken free diet taken on alternate days reduces obesity. There is no observation till now, but it improves metabolism. It generally on short term, it improves metabolism. So it goes well actually as an initial plan, but in the long run, I would not recommend it.
Yes, I think you can.
Thank you, sir. Thank you, sir. I think on the interest of time, we have to wind up. Thanks once again, sir, for joining us in this day. We know that you just finished the our national conference, and these are busy days for you again. So we would love to have you again and again in Kerala, sir. And next time, definitely we will have a physical meeting as soon as possible. Thank you, sir, for your insights. Thank you very much.
Thank you, everybody.
Thank you, sir, for the wonderful talk, and Riya, sir, for effectively moderating the session. Our next session is Pediatric Surgery in Office Practice by Dr. Senthil Ganesh, consultant pediatric surgeon and pediatric urologist, Kanchi Kamakodi Child's Trust Hospital, Chennai, and chaired by Dr. Shaji S.M., Professor, Department of Pediatrics, Gokulam Medical College, and organizing secretary of our Gokulam Pedicon 2022. We invite you, sir, to introduce the topic and the speaker.
Am I audible?
Yes, sir.
Okay. Respected senior faculty members, my dear friends, a very good morning to one and all. Thanks to the organizing team for giving me this opportunity to moderate this session. The pediatric surgery in office practice, what is new? At the outset, whenever we come across pediatric surgical cases during our consultation, it is important for us to know the latest recommendations and guidelines regarding the management of the pediatric surgical cases for the proper disposal of the case. Here we have a renowned international faculty, Dr. Sendil, to enlighten us. A few words about Dr. Sendil Ganesh Kamaraj. He is the graduate from Madras Medical College. Post-graduation.
Voice is breaking, Shadi.
Coimbatore Medical College and MCH in Pediatrics. Now, he is an internationally renowned urologist. Now working at Kanchi Kamakodi Child Trust Hospital, Chennai, and consultant to many renowned hospitals in India and abroad. He has got many awards and publications to his credit and has contributed many chapters in pediatric urology and the pediatric surgery textbooks. With this outset, I welcome Dr. Sendil to take over the session and enlighten us. Over to Sendil, sir.
Dr. Sendil?
Yeah, I'm here, ma'am. Am I audible, ma'am?
Yeah, right. You can start sharing.
Yeah, I'm just starting sharing the screen and I'll just make it a slideshow in a second, ma'am. Good afternoon to all in this August audience. I am Dr. Sendil Ganesh Kamaraj, consultant pediatric urologist from Chennai.
You can make it into full screen, Sendil. Full screen. I mean, in my system, it is playing as full screen, madam. I'm really sorry, like I'm not able to get that across. In my system, it's on a full screen. Okay, then you carry on.
Sorry about that, ma'am.
Okay.
Yeah. So I'm here to speak on common pediatric surgical problems in pediatric office practice, along with relevant emerging concepts. I wholeheartedly thank the organizers of Gokulam Pedicon for providing me the opportunity, and I hope to meet their expectations. I have divided my presentation into two parts. The first part would cover the common pediatric surgical emergencies faced in pediatric practice along with the emerging trends. The second includes recent guidelines in neurological conditions such as undescended testes, renal stone in children, and bedwetting and dysfunctional voiding. 10 to 15% of school-going kids suffer from abdominal pain, and of these kids, 5% attend the emergency room. As we all know, it's a symptom of very significant parental anxiety, and it is paramount to differential between medical and surgical causes.
Slides are not moving. Slides are not moving. I think maybe the net is slow. You can switch off the video and try.
So, sorry, ma'am, what do you want to do?
So your slides are not moving. You can switch off your video and then
your video and talk. Then the whole thing will be converted to your voice.
So you want me to close the PowerPoint, ma'am? What do you want me to do, ma'am?
Now it's okay.
Now it is moving.
Okay, fine. So I'm sorry, like I can't give you the full screen. So Basically, I've divided my presentation into two parts. The first part would cover common pediatric surgical emergencies faced in pediatric practice, along with emergent trends wherever relevant. And the second part includes recent guidelines in undesignated testes, renal stone disease in kids, and bedwetting. 10 to 15% of school-going children suffer from abdominal pain. And of these kids, it accounts for 5% of all emergency room visits. It's a symptom of significant parental anxiety, and it's paramount to differentiate between medical and surgical causes. 10% of these kids who visit the emergency need surgical intervention overall. The thumb rule in pediatric surgery is to consider significant abdominal pathology if there is persistent pain for more than 4 hours with worsening, if there is persistent vomiting, if there is onset of constitutional symptoms such as fever, and onset of abdominal signs such as distension and tenderness. There is always a need for good laboratory and radiological backup. At this moment, I need to mention the crucial role of pain relief in kids presenting to emergencies with acute abdominal conditions, right from their admission to the emergency. The reluctance to give adequate analgesia undertreats the pain and prevents crucial and accurate clinical examination in a child who is especially very much frightened. After the initial assessment, the next line of action would be to secure an IV line and send off the basic blood investigation and a radiological test once the child is stabilized. Elevated counts with or without raised CRP suggest an infective etiology as an acute appendicitis, and so does an elevated CRP and normal counts. And elevated lymphocyte counts with a normal neutrophil counts is generally viral in nature. Serum amylase and lipase are basic tests which may be elevated in pancreatitis. Radiological investigations are ultrasound, X-ray, and CT scan based on the clinical assessment. Urinary evaluation may be necessary to screen for urinary tract infection, renal stone, hydronephrosis, and rare medical conditions such as porphyria. Now, if there was one surgical disease where atypical was typical, acute appendicitis would top the list. It's the most common cause acute abdomen in children with a peak incidence of 11 to 12 years. There is a lot of variability in clinical presentation, and I've had the smallest kid that I have operated for an appendicitis around 1.5 years old. Here, only typical is atypical, the typical symptoms being abdominal pain, vomiting, and migration of pain. But there are kids who present with frequent abdominal pain and loss of appetite, and sometimes appendicitis can present as a gastroenteritis or with urinary symptoms such as urgency and frequency as well. Tachycardia is a strong pointer which I found uniformly in most of the cases of acute appendicitis. Abdominal findings are generally localized tenderness, guarding, or rigidity based on the stage of the disease. But if a child develops abdominal distension with or without the toxicity, it usually means the appendicitis is complicated. So the investigations, as we are all aware, is a raised neutrophil count with a raised CRP, which has got a 100% predictive value. However, in my practice, I've had 1.8% of patients overall who had a normal CRP and a WCC count and still had appendicitis. Ultrasound can be used in doubtful cases or where we need to convince the parents. It shows a reduced and absent compressibility of the appendicular wall with inflammatory changes. A transverse wall thickness of greater than 3 millimeters is significant, and over 6 millimeters is truly very significant. Sometimes there can be a presence of an appendicolith, and it can also show a periappendiceal mass, fat stranding, or a collection, and other signs of inflammation such as free fluid, sentinel loop of bowel around the appendix, edema, and enlarged nodes. If the rare child if the diagnosis is doubtful, there is a background of obesity and there is a very high parental anxiety, CT may be considered with its high specificity and non-operative dependence. However, in my practice, I generally suggest the patients to undergo a diagnostic laparoscopy to confirm the appendicitis because the predictive values and the specificity is much higher with a diagnostic laparoscopy than with an CT scan, when it avoids radiation as well. Management of choice of appendicitis with or without a perforation is an early surgery. As we are all aware, children will deteriorate rapidly because of the lack of vomental volume, which usually seals any inflammation around the abdomen. Right on the right side, that is an appendicular mass. So in these cases, conservative management may be followed, but however, in my practice, I generally cover even appendicular masses with very good antibiotic cover and go ahead with the operation. I reserve conservative management for the rare child who is very moribund and where the collection of the pus is truly localized. A great imitator with relative infrequency and serious consequences in kids between 2 to 12 years of age is Meckel's diverticulum. It is usually diagnosed during surgery or laparotomy for a suspected bowel perforation or obstruction with the presentation similar to an obstruction or a bowel perforation. Rest of the children are usually diagnosed followed a lower gastrointestinal bleed with or without a Meckel scan. Meckel scan is very specific, especially if the child is having a lower GI bleed. Some bigger kids can also present with an intersusception and volvulus. So, not to be left out, though I have not gone into detail, we need to rule out malrotation in bigger kids with recurrent abdominal pain or with vomiting, which can even be non-bilious. So this particular child was an 8-year-old with recurrent abdominal pain, presenting every 3 to 6 months to various physicians and surgeons. The basic investigations all proved to be normal. Eventually, he presented at the emergency with features of circulatory collapse with a primary diagnosis of abdominal sepsis. And since it looked like a surgical abdomen, we did a laparotomy which showed gangrene involving the whole of the small intestines and right colon. And that way, we have to sort of have the diagnosis of malrotation in mind, not only for neonates and infants, but also for bigger children with the with the recurrent abdominal pain and bilious vomiting. Now coming to the ovarian masses. So ovarian pathology is suspected in girls whose pain is periumbilical or present over the lower abdomen. It can be continuous or intermittent. The causes of the causes of pelvic pain in such children can be torsion of an ovarian cyst or hemorrhage. These cysts are generally more than 5 centimeters. There can be a torsion of the normal ovary, fallopian tube, or broad ligament. Sometimes there can be a torsion or hemorrhage into an ovarian tumor. Diagnosis is generally made with an ultrasound and CT scan if necessary, which will pick up the size, contents, and the blood supply of the involved ovary. Sometimes diagnosis can be made during laparoscopy for intermittent abdominal pain because of torsion and detorsion of the ovary. So the picture on top shows a normal ovary undergoing a torsion. That's the right ovary in the uterus. The picture on the bottom of the screen is an ovarian cyst which has undergone a torsion, which is the left ovarian cyst. Now, this is an ovarian tumor. It was a cystic mature teratoma which had undergone torsion. And this is an adolescent child with a bilateral polycystic ovaries and torsion. Now, the thumb rule in surgical management in ovarian torsion. In ovarian torsion, the management is more conservative. The surgical management is more conservative than with testicular torsion because ovary is a more resilient structure as compared to the testis. During the surgery, the detorsion and ovarian fixation to the round ligament of the pelvis or to the pelvis of the ovary is carried out, irrespective of the color of the ovary. Even if it's dusky and discolored, there are no exceptions. Cysts and tumors need to be excised with ovarian preservation as much as possible. Now, we should be beware of the great imitators of pain of non-surgical origin. Commonly, it used to be basal pneumonia and viral hemorrhagic fever. In the current era of COVID pandemic, the post-COVID MIS is a very important differential diagnosis with children presenting very similar to an acute abdomen. Sometimes hinox-condylant purpura and IBD can also present in the acute setting. In cases of recurrent abdominal pain, we need to have mesenteric adenitis, severe constipation, bladder bowel dysfunction, and functional abdominal pain. Mid-cycle pain need to be considered in adolescent girls. In the current era of post-COVID era, where children, as Professor Menon had just mentioned, they sit for hours together in front of the screen and they have to stay at home. This functional abdominal pain is becoming a more common presentation in children. Usually it's more common, and it used to be more common in adolescents, but now I find it more common in children of school-going age. It's called functional abdominal pain when there is no precipitating cause identified. It persists for more than 3 months. There is ongoing pain, but there is recurrent pain-free intervals when the child is cheerful and playing around as well. Generally, the painful episodes are associated with headache, abdominal pain, musculoskeletal pain, And sometimes kids present with features suggestive of appendicitis and renal colic. In my experience, I found that there are few kids who had a previous major surgeries and a post-operative period with some morbidity. They recover, and when they grow into adulthood, they sometimes present much later with very similar abdominal pain. It's a big hassle to rule the causes of pain out. Now, generally, with patience and perseverance, the abdominal pain can be treated, it resolves. But in case of non-resolving abdominal pain, medical management can be tried in concordance with a medical gastroenterologist. The first line of drug that is generally used by my gastroenterologist, amitriptyline and gabapentin in difficult cases. I have found them using clonidine as a third line of management. Now, coming to an organ-threatening condition, acute scrotum. So any kid with pain over the scrotum with or without redness is termed as an acute scrotum. The causes being testicular, the sinister testicular torsion, appendage of testis, and acute epididymoorchitis. Rarely, it can be because of henox-condylant purpura and idiopathic scrotal edema. The most sinister one, testicular torsion, is common in adolescents between 12 to 18 years, but can occur in perinatal period and early infancy, where the mechanism of torsion is a bit different. It's also frequent in adnecine testis. There is acute onset of scrotal and groin pain, usually preceded by a history of trauma or physical activity. Generally, there is nausea and vomiting. The scrotum on examination is swollen, erythematous with a tender testis, which on the lie is horizontal if it can be palpated. Cremastic reflex is generally absent, but I have found cremastic reflex to be positive in few cases of testicular torsion as well. Diagnosis is mainly clinical. Doppler can be done in bigger kids. The false negativity in smaller kids is very significant because of the small size of the testicular vessel. However, in small children, especially with idiopathic scrotal edema, where there is swelling of both the scrotum which extends down to the groin, I do use the Doppler to identify the testis and avoid an operation if it is possible. A testis is a very fragile structure, and there is a high chance of devitalization if not operated between at least 6 to 9 hours after onset of symptoms. So it needs a very early and urgent surgery. Even on a full stomach, we can explain the anesthetic risk to the parents and take the child up for surgery. So this is a testicular torsion, an intravaginal torsion in an adolescent. There was a 180-degree torsion. This testis underwent a detorsion and fixation to the scrotum in the form of an oculopexy. Coming on to the less sinister torsion appendage of the testis, it's as a result of torsion of the Mullerian remnant adjacent to the testis. It has got a peak of 11 years. This is because with the onset of puberty, there is also an estrogen surge that leads on to hypertrophy of these structures. In classical cases, the tenderness is located to the apex of the testis. Generally, the finding is usually an exploratory finding in children with an acute scrotum. Sometimes in a bigger kid who can be very clear about his symptoms and the pain is subsiding, this can be managed conservatively, especially if the surgeon is very confident of the diagnosis. Other causes are epididymoorchitis, which presents very similar to torsion of the testis, usually in smaller kids 0 to 6 months and in adolescents. It's hard to differentiate from torsion testis, excepting when there are features of toxicity. Ultrasound Doppler may be useful in bigger children. You can go with conservative management only if the surgeon is comfortable with the diagnosis of epididymoorchitis. There is nothing wrong in exploring an in exploring a child with an acute epididymoorchitis. And in a child not responding to conservative management, they may need exploration to let out the toxic fluid. And in some cases, I've let out pus from the epididymis as well. Moving on to renal and ureteric stones in childhood. There has been a dramatic increase in recent times, particularly, I guess, it's a result of the dietary changes in the environmental pattern. Metabolic disorders are very less common in the Indian population, not so in the Western population. I find almost 20 to 40% family history of stones in these kids. It can present at any age. Adolescents and bigger kids present with abdominal colic, like the classical renal colic, which is radiating, and with hematuria. Smaller kids present with atypical pain, which can sometimes be very severe. So they can be very severe, and it's usually a radiological finding. Therefore, diagnosis, ultrasound and X-ray are generally sufficient in smaller kids, but CT may be necessary in difficult cases. The American Neurological Society guidelines are very clear for surgical management of stones. Uncomplicated stones less than 10 millimeters should be absorbed. should be observed with or without alpha blockade and followed up with periodic ultrasounds. And only if the stones are unlikely to be passed spontaneously and with persistent symptoms, surgical management is indicated. In stones less than 2 centimeters, short wave lithotripsy and ureteroscopy should be the first choice. Bigger stones more than 2 centimeters need a renal puncture and a percutaneous lithotripsy. Open or laparoscopic surgery should be avoided, excepting in patients with existing anatomical abnormalities or comorbidities. And with the miniaturization of equipment and availability of the smaller flexible scope, which is seen on the left side, and the rigid ureterorenal scopes on the right side, with availability of adequate expertise, has simplified pediatric stone management as compared to the previous era. The smallest child in my series is almost about an year. This is the Holmium NDR glaser, which is the same thing that is used in adults that we use in kids. And this is a short video of breaking a renal stone. This is a stone in a lower calyceal stone, and that's the laser fiber fragmenting the lower calyceal stone. Moving on to the common undescended testis. Spontaneous descent, as we are aware, is rare after 6 to 9 months, and treatment should be completed between 12 to 18 months to preserve fertility of a particular testis. Patient clinical examination is the most important technique to accurately classify testicular location and size, and also to look for associated hernias. Penile size and urethral location become much more important in bilateral undescended testis and where there is a suspicion of disorders of sexual differentiation. Imaging is not indicated for diagnosis of a palpable testis, excepting for a renal ultrasound, look for associated anomalies. In case of non-palpable testis, ultrasound with a high-resolution transducer offers 84% accuracy in locating a testis. However, there is a 100% accuracy with diagnostic laparoscopy. MRI we use in special circumstances, especially in kids who have had a previous operation and a testicular ascent after surgery. The classification is a true undescended testis can be palpable and impalpable. These are testises which have not completed their descent, and they can be drawn into the scrotum only with some tension, as compared to a retractile testis which has completed its descent, and it can be drawn to the scrotum without much tension, but it gets drawn back to the groin after releasing it. Ectopic testes are those that are palpable but located away from the pathway of descent, like in the base of the penis, the opposite testis, the femoral or perineal region. Ascending testes are those that are normal at birth but drawn to the groin after somatic growth. So these are testes where kid is normal at birth with a descended testis, but at 3 years you find them with an undescended testis. Iatrogenic undescended testes generally follow an operation of an hydrocele or a hernia. It usually happens 6 months to 1 year later. Medical treatment with human chorionic gonadotropin is recommended only for bilateral undescended testes near the scrotal entrance with kids over 4 years of age. The best results are seen in retractile testis. Testis at the superficial pouch or at the groin has got a very low success rate, and the recommended dosage is 100 units per kilo twice a week for 3 to 4 weeks. I only used a HCG in 2 of my children, but with a negative result. So surgical management for a palpable testis is a transinguinal orchidopexy, as in this picture. In case of a non-palpable testis, diagnostic laparoscopy is the management of choice. So this image shows the diagnostic laparoscopy. The testis is just proximal to the deep ring. The vas and vessels are seen entering the testis. So such testes can be brought down to the scrotum either by a single stage or a 2-stage procedure, depending on their proximity to the deep ring. Now this is another image. We can see the vas difference and the blood vessels entering the deep ring, but there is no testis seen. So this usually implies that there is a dysplastic testis in the groin, and it needs a groin exploration and removal of the testis. Now, what's new in undescended testis? Now, the justification for an early operation. So, undescended testis have impaired maturation of the spermatogonia in the tubules and a reduced pool for later spermatogenesis, resulting in reduced sperm production in adulthood. And there is an impaired apoptosis of the undifferentiated germ cells, which can result in malignancy in puberty. Contrary to previous thought, bigger boys can also undergo orchidopexy with an undescended testis, but they warrant a testicular biopsy to look for intratubular germ cell neoplasia with specific stains, which can predict later development of testicular cancer, and they can be followed up with a testicular location. Screening and self-examination both during and after puberty is recommended for all children undergoing operation for an undescended testis. Now coming on to the last topic, pediatric urologist perspective of bedwetting in children. Wetting in discrete portions while asleep in a child who has passed his or her 5th birthday, according to International Children's Continence Society, in the absence of congenital and acquired neurological disorders, is termed as bedwetting, which simply means wetting during sleep. So we classify bedwetting into monosymptomatic nocturnal enuresis, which is enuresis in children without any other lower urinary tract symptoms. Non-monosymptomatic is nocturnal enuresis associated with lower urinary tract dysfunction and symptoms such as urgency and frequency. A secondary enuresis in a child happens in a child who has been previously non-enuretic or dry for more than 6 months. And in such children, upfront, we should be thinking about neurological or spinal disorders. Modern research has established 3 pathogenic mechanisms as crucial to bedwetting. They are nocturnal polyuria, that is increased urine production at night, deep sleepers or increased arousal threshold, and dectus or overactivity at night. So mismatch between the 3 results in bedwetting. A patient clinical history is paramount in reaching the diagnosis of monosymptomatic nocturnal enuresis. So comorbidity is more common in secondary enuresis. Regular bedwetters generally respond much more poorer to therapy. When there is generally a poor response to alarm therapy if the wetting is sporadic. Now, in children with lower urinary tract symptoms, we should check for detrus or overactivity and non-monosymptomatic nocturnal enuresis. A weak stream, interrupted stream, or straining to void warrants an ultrasound and a neuroflow if necessary to rule out anatomical problems. Children in recurrent UTIs also need an ultrasound. Constipation, as we are all aware, needs to be managed ahead of the enuretic therapy. Alarm therapy may be of no use in deep sleepers. And then if psychological assessment is beneficial if there is a clinical suspicion in order to improve the results of therapy. And one needs to rule out neurogenic bladder if we are suspecting a motor deficit. Children with nausea, weight loss, and excessive thirst need to be ruled out for renal disorders. Urinary evaluation is done, especially when the referrals are direct to rule out medical conditions such as diabetes insipidus. Abdominal ultrasound is done in children with recurrent UTIs and lower urinary tract symptoms along with the bedwetting, and if there are obstructive symptoms and constipation. During the ultrasound, we need to look for the rectal diameter, which can confirm the severity of constipation, and also for post-void residuals of urine, especially if considering therapy with anticholinergics. Generally, treatment is commenced with urotherapy and bladder training before any medical management, which basically means optimizing your fluid intake, toilet visits, bladder emptying and posture, and management of constipation if present, along with lifestyle advice. If unsuccessful, and especially in children over 6 years of age with persistent bedwetting, rather than the occasional one, medical management can be common. Generally, alarm therapy is preferred when there is a low nocturnal urine production. Basically, if child wets the bed just once in the night and with a small functional bladder volume, which is usually ascertained by the frequency bladder chart. Desmopressin is used when there is a large nocturnal urine production, like the child wets the bed 4 to 5 times in the night and there is a normal functional bladder capacity. See, both modalities should be regarded as complementary and not as competing modalities. And many children have a combination of both these archetypes. So, enuresis alarm achieves dryness in 2/3 of the children. It basically conditions effect of arousal and increasing the bladder reservoir function. So, this is the enuresis alarm that I'm currently using. So, the alarm can be fitted on to the shirt or to the arm, and that is the probe which is fitted on to the underpant. That will wake the child up with an alarm or a vibration at the first point of contact with urine. So these children, once the therapy starts, you need to follow them up after 2 to 3 weeks to provide them encouragement and motivation. We need a minimum trial of at least a couple of months before we give up. But once the therapy is successful, it has 14 dry nights before we stop the therapy. And we can consider enuresis alarm in motivated parents in children. But nevertheless, moderate intellectual impairment is not a contraindication. Desmopressin, there is a very good response, especially in children with increased frequency of bedwetting in the night, around 4 to 5 times. And it can also be used in children with failed alarm therapy. The option is between the tablets and the lyophilizate. I'm using the lyophilizate for now, the melts that are left under the tongue. The initial duration of treatment is 2 to 6 weeks when we actually titrate and achieve the ideal dose, which is followed by 3 months of maintenance therapy and structured withdrawal. We should caution the patients to limit their water intake to about 1 to 2 hours, especially if they're using the tablet, but can be limited to only 30 to 60 minutes if we are using the lyophilizate. Fluid intake has to be restricted for about 8 hours after. We need to forewarn them about the side effects and that self-titration over medication can lead on to water intoxication and toxicity. So in children where the second line of management has failed, before jumping on to the third line of medical management, it is always worthwhile to pause and then exclude constipation, non-compliance with medical management, reassess the frequency volume charts, and exclude dysfunctional voiding and high post-void residual before considering the third line of management. Third line generally includes anticholinergics, which is effective in 40% of the children, can be used in combination with desmopressin. The anticholinergics of choice are oxybutynin and tolterodin. It's usually effective within 2 months of therapy and needs a successful withdrawal attempt every 3 months. The more popular tricyclic antidepressants like imipramine are not so frequently used or not recommended by ICS, excepting for the third line of management because of the risks that go with it. So the dosage recommended for TCAD is 25 to 50 milligram at bedtime, and it is usually it is much more effective, usually effective within the month, but it needs regular drug holidays because the patients develop tachyphylaxis to the drug. So I can pause my topic for now, but if with the permission of the chair, I can proceed on with the last topic, the dysfunctional voiding disorders.
You can take just 1 minute on this.
Okay.
Sure, madam. So dysfunctional voiding disorders are much more common in kids around this age of toilet training, which is usually 3 to 4 years. And it usually presents with symptoms such as dribbling, urine, urgency, frequency giggle incontinence, and it's particularly in kids who have been previously toilet trained, or it's around the time of toilet training, which is 3 to 4 years onwards. So after the initial assessment, a good history should rule out neurologic and functional bladder disorders. Good clinical examination to rule out abdominal spinal disorders and look for fecal masses. And urine analysis should be done to yes, because asymptomatic bacteria is commonly seen in kids with dysfunctional voiding. A renal ultrasound rules out structural anomalies. We use a test called as Euroflow, which can sort of screen for dysfunctional voiding disorders without having to do an invasive urodynamics. So this is an Euroflow study. Euroflow study on the left side is of a normal kid, it's showing a bell-shaped curve. That of a dysfunctional voider in the right side shows that the curve is a bit, it's a staccato pattern with the sphincter sort of resisting the flow of urine each time, where there is dysfunction between the bladder contraction and the release by the internal and external sphincters. And for resistant patients, we can use urodynamics, MRI, spine, cystoscopic examination to rule out other disorders. I just want to focus on this and probably complete my talk. So management of voiding disorders mainly involves urotherapy. Urotherapy is nothing but bladder training, like what I mentioned in children with bedwetting. Basically, teaching the children how to sort of fill and empty the bladder at regular intervals, rather than holding on to their urine or delaying to the void or delaying their voids. This is called standard urotherapy. And it also, we have to manage the constipation as part of bladder training. Pharmacotherapy like anticholinergics are usually kept as reserve if the children fail this sort of standard urotherapy and treatment of constipation, we move in for anticholinergic, which are the commonly anticholinergic I'm using now is I don't use oxybutynin because of the constipation. I use tolterodin, which causes much less constipation, much more selective on the bladder. Surgical intervention. Surgical intervention is generally in the very severe intractable case. We find a lot of these kids around 10 to 11 years. They have this condition called as a Hinman's bladder, which is a severe form of non-neurogenic neurogenic bladder, which is presents like a neurogenic bladder, but otherwise there is nothing in the spine. So these children may sometimes need cystoscopy and intravesical Botox injection. Thank you very much for the patient listening.
Hello.
Yes, sir.
Yeah, thank you, Dr. Sendil, for covering the vast subject in time with the excellent pictorial representations. Thank you so much. Dr. Leah, any queries in the chat box?
No, sir.
No worries.
No queries.
Hello.
Okay then. Thank you, Sendil, and thank you, Shaji, for moderation as well as for the effective session. Sendil, can you stop sharing?
Sir, definitely, madam.
So I think because of we're running short of, they're running very late, I think we'll happily proceed to the next session. The next session is on chronic urticaria by Dr. Vijay Kumar, who is the professor of dermatology in Stanley Medical College, Chennai. And he's a very much sought after speaker in national as well as specifically in Kerala. And to chair the session, we have Dr. T.U. Sukumaran, who is the retired professor of pediatrics from Government Medical College, Kottayam, and after that, professor and HOD from Pushpagiri Medical College. And currently, he is working as a senior consultant pediatrician in Caritas Hospital, Kottayam. And he was the national president-elect of IAP in 2011. After that, president of the IAP Respiratory Chapter, and currently very active in the Allergy and Immunology Chapter. More than above all that he's a very close friend of mine from our PG days. A very warm welcome to you, Sukumaran, and over to you to introduce the speaker and the topic. Thank you.
Okay. Thank you, Dr. Lalita Kailas, and my dear friends. It gives me great pleasure and privilege to be here with you to participate in the CME program of Gokulam Medical College as usual. And I'm very happy to chair this session by Dr. Vijay Kumar, because Vijay Kumar is a very, very close friend of mine, and he is there always in all the IAP national and state conferences. I had the fortune to meet him, and he had a very brilliant academic career. He has got his DCH from Madras Medical College and MD in dermatology from Madras Medical College. And at present, he's the professor of dermatology in Stanley Medical College. And one thing more to say is that he was the charter secretary and charter treasurer of the dermatology chapter of Indian Academy of Pediatrics. And now he will be talking on urticaria. As you all know, urticaria is a very common problem in pediatric practice. It will be either acute or chronic. Acute less than 6 weeks and chronic more than 6 weeks. And there are a lot of causes for chronic urticaria also. And with these words, I have great pleasure to invite my friend Vijay Kumar to start his talk on. Please start.
Sir, thank you, sir. Thank you for the nice words. Very good afternoon for one and all. And I really thank the Gokulam Pedicon 2022 for inviting me for this lecture. So we'll right away go. The topic given was challenges in urticaria, but I find everything is challenging in urticaria. So everything is challenging in urticaria. Sometimes even I used to think when chronic urticaria patients come, why these people are coming to me? So many people are going to other doctors. Why this person is not going to other doctors? No, it is very difficult situation to manage. I can understand. But so I thought we'll have a basic idea for a practicing pediatrician how to manage an acute and chronic urticaria. For that, we have to have some basic idea about urticaria. So it will be useful if you have that. And there are so many types of urticaria also that one should be aware. So it will be easy for their management. So we all know that this is an urticaria which we of course come across in most of the pediatric practice. At least 30 to 40% of the patients will have. I always used to tell there's 3 E's, the definition of urticaria: erythematous, edematous, evanescent rash. Suppose if it is associated with dermal edema, we call it as an angioedema. But most of the time, this urticaria, in most of the, I think the 30 to 40% of the practice, we come across this urticaria in one form or other. And normally we classify this urticaria as acute and chronic. Acute, as Dr. Sukumaran has already told, it is when it's less than 6 weeks, we call it as acute urticaria. And when it is more than 6 weeks, we call it as chronic urticaria. And again, in chronic urticaria, we have chronic spontaneous urticaria, like it keeps on coming. And some of them are chronic inducible urticaria. You can induce, some of the factors can induce these urticarias. This is how it is classified. And in chronic spontaneous urticaria, the main reason, most of the time, we don't know the reason, it's idiopathic, but sometimes it could be an autoimmune causes in most of the conditions where there will be more of IgG autoantibodies to the IgE. And sometimes these chronic spontaneous urticaria can be associated with Helicobacter pylori, and it may be associated with autoimmune diseases like systemic lupus erythematosus, thyroid diseases, celiac diseases, and sometimes other autoimmune diseases like vitiligo also, it could be associated. So we have to be careful in taking an history in these patients. And the aggravating factors in chronic spontaneous urticaria could be a heat, or most of the time an infection. Nowadays, particularly after this COVID, we can see a lot of COVID also bringing out urticarial lesions, and sometimes the food can aggravate it, and some of the drugs can aggravate this urticarial lesions. And when we are talking about the chronic inducible urticarias, like dermographism is one, which will appear like that is it will appear like this. Wherever you stroke, you will get a linear lesions, and then it will disappear after sometimes. As long as they don't give any trouble, it's nothing to worry about it. And next we have cold urticaria, then cholinergic urticaria, contact urticaria, like delayed pressure. After you give a pressure, after some time they'll develop urticaria in that region. And solar urticaria, whenever they get exposed in the sunlight, they can get urticaria, heat urticaria, and vibratory urticaria, and of course aquagenic urticaria, particularly when you take bath. After 15 minutes, they can start scratching the whole body, and after another 15 minutes, it may disappear also. So these, in those days, they were called as physical urticarias. Nowadays, we call this as chronic inducible urticarias. So we'll see one by one. And these chronic inducible urticarias, they usually appear within 5 minutes after a stimulus, and they may last for a few minutes to an hour. And if you see the dermographism, they'll look linear. They have a characteristic features. It will be linear like this in case of dermographism. And in case it may be very tiny in case of cholinergic urticaria, like that very tiny urticaria lesions you can see in cholinergic urticaria. And of course, it can be confined to a particular area in contact urticaria, like when you sit in for a long time in the gluteal region, you can develop, or you carry a bag on the shoulders, you may develop this contact urticaria. And the cold urticaria, it can come diffuse. The whole body can get involved. Sometimes it can be very dangerous. It can lead to even breathing difficulties, particularly when they go for swimming. When they have a cold urticaria, it can lead to diffuse urticarial lesions, and it can be dangerous also. And coming to a few lines about angioedema, it is more often localized, and it can come commonly over the face, particularly on the around the eyelids and perioral regions. It can also occur on the hands, feet, and the genitalia. And sometimes, very rarely, it can occur on the uvula, soft palate, tongue, or the larynx. When it occurs on the larynx, definitely it's a medical emergency, what we come across. And I will now split it into acute urticaria and chronic, and then we'll go for the chronic urticaria. This is my, normally we have to ask an history for this acute urticaria. All eyes you have to remember. One is infections, any infections for that matter. It could be viral, it could be bacterial. As I told you, it could be COVID infection also, anything can cause. So that also you have to keep in mind. Second is any ingestion of food. But many people give a lot of stress to the food, but 5 to 20% only could be a food could be a main cause for this urticarial lesions. So food is one. Then ingestion of drugs also you have to keep in mind. That is any drug that has been taken 2 to 3 weeks prior to the onset of urticaria. Any new drugs, those drugs also has to be kept in mind for evaluating an acute urticaria. Sometimes inhalations like your pollens, and instillation, your eye drops, ear drops, nasal drops. Most of the time they don't give this history because we also don't ask about it. So you have to ask about that. Those also can be a cause for urticaria. And of course, insect bites and infestations, worm infestations in children and protozoal infestations in adults could be one of the reasons. And very rarely, even immunizations. Immunizations can cause urticarial lesion, but not so common, but it could occur. And of course, the biggest chunk is idiopathic. We don't know the cause, right? In more than 50, or I can tell you 70% of my patients, I am not able to find out a cause. If we are able to find out a cause, it is very easy to treat. And if possible, you try to find out a cause of the history. And investigation, generally, I don't do for any acute urticarias. So You can go ahead with a short course of oral steroids also along with antihistamines, but you have to put the antihistamines for at least 3 to 4 weeks. In the later part, I'll talk about the antihistamines also. And so at least for 3 to 4 weeks, there is no point in using it for a day or for 3 days, 5 days like that. You have to use it. And I always prefer to use double antihistamines, 2 antihistamines, one non-sedative in the morning and a sedative antihistamine in the evening. And then after 2 or 3 weeks, I cut down one and I maintain with one more for another 1 more week. If they don't have any problem, then I stop that. But if you take the guidelines, they say non-sedative antihistamines are better. In my option, I use both non-sedative and sedative antihistamines in children. And coming to the investigations for spontaneous urticaria, that is, the urticaria is present for more than 6 weeks. We know that it is very difficult to manage. Here, there is a role for investigations. You have to do a CBC, you have to do an ESR, CRP, and of course, I have mentioned it may be associated with thyroid disease. So thyroid antibodies and thyroid function test has to be done. And to rule out any collagen vascular disease, we have to do an ANA also. And of course, if you're thinking about angioedema, where there will not be any urticaria like hereditary angioedema, where there may not be any urticaria, where you may have to do a C4 complement, where there will not be any urticaria lesions there. And of course, very rarely we come across Helicobacter pylori as the major reason where your stool antigen or urea breath test can be of some use. And even you can do a stool for ova and cyst, and X-ray chest mainly to rule out any other malignancies also has to be taken care when there is chronic spontaneous urticaria for a longer period of time. And of course, now vitamin D has been talked in most of the thing. The optional test, you can go ahead if you find nothing in the investigations, you can try and do a vitamin D also. Because there are few studies which have shown that vitamin D are deficient in these urticarial children, and when you come supplement it, they become all right. And of course, you have to ask the patients to maintain a food diary. That is very, very important. Whatever they have taken on the previous day or on that particular day, they can maintain a food diary. If it's a bigger child, if it's a smaller child, the parents can maintain a diary, and they can compare when the urticaria recurs again after some time. They can compare what is the common food between the two, or they can try a food and see whether that is the one which is inducing it. So these things are very important. And skin prick test, generally, this is more useful in children with allergic rhinitis and bronchial allergy rather than in urticaria. So I don't do much of skin prick test, and we get more of false positive and false negative results also here. So I prefer not to do a skin prick test in this chronic urticarial children. And of course, you can, whenever you are treating the child, we can monitor with your UAS score, the urticaria activity score. Of course, this is present in most of the textbooks. You can go through in the textbooks that you can see whether they are improving or not. So what are the general measures you will advise for chronic urticaria when they come? They are non-specific measures like loose fitting clothes, cotton clothes, that also to some extent it can help. And of course, your soothing lotions like your calamine lotion can help in bringing down the itchingness. And you can also advise them to avoid overheating. And also one of the main problem is stress. So at least the parents can reduce the stress on these children to some extent in this chronic urticarial disease. And of course, the first line of therapy in any chronic urticaria or acute urticaria is going to be H1 antihistamines. And particularly, we know that the first generation antihistamines like chlorpheniramine malate and hydroxyl hydrochloride are excellent drugs. But the main disadvantage of these drugs is they can cause sedation, they may have anticholinergic activity, and sometimes paradoxical excitation also can occur. I can tell you that hydroxyl hydrochloride is one of the best antihistamines I can tell. Even a 25 milligram of hydroxyl hydrochloride is equivalent to 10 milligram of cetirizine. It is very effective. But the problem is it can either cause sedation. In 50% of the patient, it can cause excitation also. That is one. And second thing is you cannot use hydroxyl hydrochloride for a longer period of time because it can have tachyphylaxis. It's the only antihistamine which has got tachyphylaxis. So normally for acute urticarias, you can prefer this in small babies like below 6 months of age, you can prefer this. Otherwise, most of us use the second generation antihistamines. They are the treatment of choice because of the advantages, low sedation and minimal anticholinergic effect. But coming to the part of sedation, I can tell one thing. All these antihistamines, sedation is only individual based because one person may have sedation and the other person may not have sedation at all. So we cannot go by that. Even I have seen that first generation antihistamine doesn't produce sedation at all, whereas the second generation antihistamines can produce a lot of sedations. Of course, the best drugs we use is cetirizine and levocetirizine. Of late, there have been some studies telling that cetirizine is almost equivalent to levocetirizine in the action part of it. And of course, we use a lot of cetirizine and levocetirizine, and fexofenadine can be used. and loratadine and desloratadine also are good antihistamines which can use it. And of course, H2 blockers also helps in chronic spontaneous urticarias. Normally, they don't have an anti-itching properties, but they act on the vessel wall so that the vasodilatation will go down, the erythema and the edema will go down along with the usage of ranitidine. That is how we normally, that helps in the management of the chronic urticaria. So, and we all know that below 6 months of age, the better drugs will be chlorpheniramine maleate and hydroxyzine hydrochloride will be a better drug of choice. And above 6 months of age, the approved drugs are cetirizine, levocetirizine and fexofenadine can be used. And above 2 years of age, we can go for loratadine or desloratadine that can be used. And once we fail with this, normally what I do is I always go for double antihistamine. In case I don't get much response within 2 weeks or 3 weeks, I either escalate the dosage of the antihistamines or I switch on to another antihistamines. In case if all these things fail, then the second line of management will be, if it is going to be a very severe form as an acute and chronic urticaria which occurs, you can go for a short course of steroids, but please remember, do not use steroids for a chronic urticaria in a long run. Okay, it is only for a short course. When they have very severe form of disease, you can use that. And of course, with the antihistamines, you can go for Montelukast also can be tried in these patients, but the action taken for this Montelukast, which definitely is going to take a longer period of time. So you have to wait for a month or two along with the other antihistamines for the effect to be seen in these children. Of course, when these things fail, the third line therapies will be your immunomodulatory therapies. For IVIG, we can be given like 0.4 grams per kg per day for 5 days can be given. Or another drug of choice will be cyclosporine. It's 2.5 to 3.5 milligram per kilogram per day. For 1 to 3 months, we can use it along with the antihistamines. And of course, I have not used plasmapheresis. For completion sake, I have put there plasmapheresis, oral tacrolimus, and mycophenolate mofetil also has been used, but I have not used any of them. Even IVIG I have not used much. And of course, cyclosporine we have tried in a few patients with chronic spontaneous urticaria, which is very severe in children. And of course, the fourth line of therapy was omalizumab. This is a biological. It can be used along with that. Again, once in 3 to 4 weeks, we can use this. It can be used above 6 years of age group safely. But the problem is I have tried omalizumab in a few patients, but I didn't find much response. And I discussed with my respiratory colleagues. They were telling it has got a good response with the bronchial allergies or your bronchial asthma. It has got a good response. In my experience, I have not get good results with omalizumab. These are the guidelines that has come out in 2017. This is the European guideline where they say that you have to start with second generation antihistamine like cetirizine or fexofenadine. If there is inadequate control after 2 to 4 weeks, then you can even step up the dose. You can go up to 4-fold the dose like your levocetirizine or in the fexofenadine you can use. And still you have an inadequate control, then you can switch on to omalizumab. That is the European guidelines, what I am telling. And still you haven't, it is not coming under control, then you can go for cyclosporine. This is one of the guidelines. And the other guideline, what we normally come across is, the other guideline is your Italian guideline that says, again, you can step up the antihistamine if it is not getting under control. And if still you are not getting under control, then you can go for omalizumab or you can go for other Montelukast or cyclosporine. So normally these are the guidelines what normally they do. What do I do for my chronic urticaria patients? How I manage? I normally use a non-sedative antihistamine in the form of our low sedative antihistamine in the form of cetirizine or levocetirizine or fexofenadine in the daytime, and I go for a low sedative like your hydroxyzine for a shorter period of time or other antihistamines at night time. If they are not responding after 2 to 4 weeks, I start adding a H2 blocker in the form of ranitidine I use, and if still they are not responding, I add Montelukast, and I have to wait for a month or two before I know that this is not working. Still, if it has not worked for this, and most of the time my patients, it works for them, and then I move on to cyclosporine. This will be my next choice. And as I told you, I use omalizumab, but I have not find much benefit with omalizumab in my experience. It may differ from person to person. In my experience, I have not got good results in children particularly. And in cholinergic urticaria, coming to the inducible urticarias, we can see the children playing, they get a lot of sweat, they come with cholinergic urticaria. I find that cetirizine is better acting in those type of children. And we ask them to avoid sweating, which is very difficult in children. That is one. And of course, there is solar urticaria also that is present whenever they venture to the sun. they get, particularly the place where that has been not exposed to sunlight, those are the places they get urticarial lesions in solar urticaria. And of course, avoidance of sunlight, and of course we can go for antihistamine, those type of children. And there is one more urticaria, which is aquagenic urticaria. I have a few children with aquagenic urticaria. That is, whenever they take bath, they get urticaria after 15 minutes. After 15 minutes, either they can have aquagenic pruritus or they can have aquagenic urticaria. Most of these lesions will be very small in size, and they have severe itching for 15 minutes or 20 minutes, and after that it disappears. First thing you have to rule out in these type of patients is polycythemia vera. There is one we have to rule out is polycythemia vera. And of course, I get a good benefit with soda bicarbonate powder, like ordinary the powder what we use for this idli and dosa. Those soda bicarb can be used 25 grams to 200 grams. You can mix it in a bucket of bathing water, and they can take bath in this bathing water. That gives excellent results for this aquagenic urticaria. So this is how I manage the urticaria. So it is only individual based again. So each person will definitely respond in a better way. I mean, each antihistamines will work in a different way in each individual. So you have to keep on changing the drugs. That is the only way I find good results with urticaria. And this chronic spontaneous urticaria, I have seen that children, they have been on treatment even for 5 years. After sometimes they go down. So the main idea of treatment is to bring down the symptoms in these type of urticarial children, and you have to give a very stressless life for them. That is, so that they can enjoy their studies and they don't have any disturbance in the sleep also. And also the parents will be very, very happy if you can able to control the disease in them. So you have to use it for a longer period of time, all these antihistamines, maybe for sometimes months or even years. And then you try to stop in between and see if they again get back the lesions, then you have to restart those medicines. And whenever you are using two antihistamines, like one non-sedative in the morning and a low sedative in the night, you don't stop both the antihistamine at the same time. You have to give time. First, you stop one of the antihistamines, and then you continue with the other antihistamines for another 1 or 2 months. And if you don't get any urticaria in between, then you can try and stop and see for a good results. This is how I manage an urticaria, and definitely it is a challenging one. So all pediatricians, it's very, very easy for them to manage an acute urticaria. It is very, very easy. But 20% of the children of this acute urticaria will definitely grow for chronic urticaria, and that is where we find the problem. But still, with a good combination of medicines, we can easily manage. So a small pediatrician can definitely manage a big disease like this urticaria very efficiently. Only thing is you have to take a proper history, and you have to use judiciously how to use the antihistamines. Definitely you will succeed in that. And I really thank once again Dr. Lalita Kailash and the whole team of Gokulam Pedicon for giving me an opportunity. I thought with this short period of time, I thought this is what I could present for the chronic urticaria, and I hope it was useful. And any questions, I am ready to answer. Thank you.
Okay. Thank you, Dr. Vijay Bhaskar, for an excellent presentation. It was very excellent. But some of the confusions are still there, because in most of the guidelines, especially the European guidelines, they say that you must give a second generation non-sedating antihistamines. And I have seen that doubling the dose or 3 times the dose, even 4 times the dose of the dose of the drug will be more beneficial before you change to a second drug, either 2 times or 3 times.
Sir, but one thing is, sir, I think if you don't mistake me, or if any pharma company is sponsoring the session, I'm sorry to tell that most of the guidelines, are pharma driven. This is what I will tell. Unless we have the practical experiences. I have tried 4-fold increase of these drugs, 3-fold increase. To be very frank, they were not working for me. So I have to go for combination. And they say you don't use the first generation antihistamines at all. And because it can induce sedation, they cannot go and attend the school. But still, I told you the sedation part is only individual based. It is not the same for all. So of course, I follow the guideline wherever possible. Otherwise, I break the guidelines. Sir. To be very frank, I have tried the 4-fold increase of cetirizine, levocetirizine, and your desloratadine and fexofenadine, but I don't have much benefits. In a few patients, yes, we had it. So I have to deviate from the guideline. That is the reason I told you these are only guidelines. Only practically how we deal, that definitely works. So you have to keep on trying. So you can go for non-sedative like fexofenadine and all. You can safely go up to 4 times. But I stop with 2 or 3 times, and then I switch over to some other antihistamine if it doesn't work.
And one more thing is regarding montelukast. I think there is most of the guidelines say that montelukast is not going to be effective in isolated chronic urticaria. And somebody has asked a question. This now Montelukast is not available alone. Lot of Montelukast are available now without a combination. And Dr. Anand was asking a question. It is very difficult to get Montelukast alone. I think isolated Montelukast is very, very easily available now. It is available. So,
sir, I don't prefer any combinations, to be very frank.
yeah,
I
right.
always use Montelukast separately and levocetirizine if I want to use separately. I normally advise them to take the Montelukast by 6 p.m. I think
Right.
there are some studies which have shown that there is a very good effect by 6 p.m. I don't know how, to be very
Yeah,
frank. So
yeah.
I always use separately. I don't combine the combination.
See, when you decide the pharmacology of this this Montelukast, it is better to give by 6 p.m.
Yes, sir. And
Always give it 6
Montelukast
p.m.
alone
Ask the
will
child to
not
chew it.
Yes, sir.
It will
And
not be available.
Montelukast alone will not help. You have to go under the cover of antihistamine. That is very important. So Montelukast alone will not help.
So you get separately
But I
Montelukast
give
and
separately.
separately. Listen. Thank you very much. So once again, I thank Dr. Lalitha Kailas for giving this opportunity. Thank you very much for your patience listening. Thank you.
Thank you,
We'll
sir.
wind up.
Thank you, Dr. Vijay Bhaskar, for that excellent presentation, and thank you, Sukumaran, for sparing time with us. So I think because we are running late and moving ahead with the next session, we are going to have is the problem solving in vaccinology, case-based scenarios by none other than Dr. Kashi. He is the man of vaccinology in India. And to a very warm welcome to you, Dr. Kashi.
Thank
And to
you.
chair the session, we have Dr. K. Elizabeth with us. I don't think Dr. Elizabeth needs any introduction to this group. He was a retired professor and HOD from Department of Pediatrics, SAT Government Medical College, Trivandrum, and right now she's heading the Department of Pediatrics in Mugambika Medical College. And she's a very active person in all aspects of IAP, be the nutritional chapter, IYCF chapter, or whatnot. The latest feather she has added to her cap is the UNICEF consultant for the state of Kerala. I'm very happy that you could make it for the day, Elizabeth, and may I invite you to carry forward the session by introducing the speaker and the topic. Over to you, Elizabeth.
Thank you, ma'am, for the kind words. Big salute to Madam and the Gokulam team for this meticulously doing it every year and making it very interesting. Actually, when we look at vaccines are the tugboat of preventive health, but that is the one which has fallen prey to its own success. People now speak only about the side effects of the vaccine. They are not seeing the diseases per se. And now we understand that the vaccine resistance is maybe very less. The true vaccine resistance is very less. That is what COVID-19 has taught us. And problem solving in vaccinology is a very interesting topic. And we have none other than Dr. Srinivas Kashi from Bangalore to be with us. And he has been in office of Indian Academy of Pediatrics, Bangalore, Respiratory Chapter. And he is the doyen, we must say, of the advisory committee of vaccinology for Indian Academy of Pediatrics and the faculty and the architect for the vaccine course run by IAP. And he has, to his credit, a lot of publications, 4 endowment awards, and 3 orations. And recently in the Indian Academy of Pediatrics group, Sir posted about onco-VCG. And finally, he himself came out with the the problem solving, also contacted Dr. Jacob John and posted it. I think I leave it to Sir to go ahead and present the whole story of problem solving in vaccinology. Over to you, Sir. Welcome.
Thank you, Elizabeth, Madam, for the kind introduction. At the outset, I would like to I'll just share my slide. Yeah, at the outset, I would like to thank Dr. Lalitha and her team for inviting me to be a part of this very popular CME. I took part in it last year, and I don't remember if a year before that, but I really enjoyed taking part in this discussion. Now, just imagine you're in your vaccination session in your clinic, and a patient walks in, a child with nephrotic syndrome on steroids, or for that matter, a child with juvenile idiopathic arthritis who is on methotrexate. And then you start wondering, should I vaccinate this guy? Will it be safe? Will it work? And that exactly is what is a special situation. So a special situation is a situation in which administration of vaccine may result in either a suboptimal efficacy and or increase the chances of serious adverse effects. Remember, special situations are never a property of the vaccines. It's either something inherent in the vaccine or the administration process itself. Now, many special situations, you can broadly divide them into immunodeficiency disorders and other situations. Well, in immunodeficiency disorders, I think almost 90% are children on steroid therapy. And in other situations, which are probably more common in clinic practice, someone has come too early, too late, very tiny, child has received some medications. You know, these are the conditions where doubts arise about the efficacy of the vaccine. So let's begin one by one. Now, we all know that the first dose of vaccines are administered at 42 days of age. But, you know, in one case, some error occurred. You know, that discharge summary was written in a pen and what was 11 was mistaken as 17th, the date of birth. And on 35th day of life, the vaccine was administered. That is the usual 6 weeks vaccine, which was the hexavalent, the pneumococcal, and the rotavirus vaccine. So here the child has received the vaccine almost 1 week before. So the question is it a valid or an invalid dose? Well, I say it's an invalid dose. I'll give you the reason why it's invalid. And if it is invalid, do we have to repeat it? When do we repeat it? So what do the guidelines state? When vaccines are administered less than 4 days before the minimum interval age, those doses are considered as valid. Less than 4 days. And what is day one? Day one is the day before the day that marks the minimum age or minimum interval. Okay. So in this case, it was 42 days. The count begins at 41 days. So 41, 40, 39, 38. So anything given before 38 days is an invalid dose. This dose is to be, this dose is to be repeated after the invalid dose by the recommended minimum interval. So what is going to happen in this child? 4 weeks after the early dose, you are going to repeat a dose. The first dose is invalid. So in essence, this child is going to receive 4 doses of the hexavalent, pneumococcal, and the rotaviral vaccines. So this is how the recommendations are as far as vaccines which are given very early. Or what if the child is too tiny? You have a 31-weeker, 1.2 at birth, but he's a healthy baby, not on any support. Will you give the neonatal vaccines? Will it work at this tender age? Or what if he comes at 7 weeks, but weighs less than 2 kgs, just 1.9? What about the 6 to 7 weeks vaccine? So what are the recommendations? All vaccines may be administered as per schedule according to the chronological age, irrespective of birth weight or period of gestation. So in essence, it means this 31-weeker can receive BCG, OPV, hepatitis B. Even at 7 weeks, he can receive all the 6 to 7 weeks vaccine. Okay. Now, BCG and birth dose of OPV can be very safely given once stabilization has been done. There is a caveat which we always followed, that in babies less than 2 kgs, the birth dose of hepatitis vaccine should be delayed for a month after birth, as immunogenicity is lower if given earlier. But infants born to HBsAg positive mothers, ignore this and give the birth dose, but don't consider as valid. But in 2017, a revised recommendation by the WHO came, wherein it stated that all infants, including the low birth weight and premature infants, should receive their first dose of hepatitis B vaccine as soon as possible after birth, ideally within 24 hours. Mark the letters in the bracket, including low birth weight and premature. And why did this come? Nothing has changed, but now our schedule has changed. We are giving a birth dose plus 3 additional doses of hepatitis B at 6, 10, and 14. And we all know 3 doses of hepatitis B given with a minimum of 4 weeks interval between the dose elicits a very good seroconversion, which is almost equivalent to the 016 schedule. So hence, no discrimination against premature and low birth weight. They are going to be treated like full-term babies itself. How many vaccines can you give together? Take this. We just went to just coming out of the COVID. This was a 3-year-old child who took the last vaccine from me at 1 year of age. 2 years he didn't come to my clinic. So he had missed his MMR, varicella, PCV booster, DPT combo booster, and the second dose of hepatitis A. And to add to the confusion, they had to travel abroad after 4 days. And they said, I just want to complete the schedule as soon as possible within the next 4 days. Can all the vaccines be administered on the same day? Are there any caveats that certain vaccines should not be introduced the same day? So what are the recommendations? First, any number of antigens can be given safely on the same day. So the only limiting factor is the parental assent to this particular multiple doses. If you're giving 2 doses, give it on different arms or legs. If you're giving more than 2 doses, you have to give 2 or more doses on the same limb. In that case, maintain a distance of at least 1 inch between the injections. There is really no immunological reason. It is just that you do not want local reactions to overlap. That's why you keep a distance of about 1 inch. Now, what are the guidelines for spacing of the vaccines? If you are giving 2 or more inactivated vaccines, like you're giving the hexavalent vaccine and the PCV, you can give it on the same day, 1 day later, 4 days later, 10 days later, it makes no difference. If you're giving an inactivated and a live vaccine, again, they can be given on the same day or at any interval. But if you're giving 2 or more live vaccines, either given the same day or 28 days interval, like if you're giving MMR and chickenpox, same day or 28 days apart. And as I said, maintains a distance of 1 inch. Now, what are the exceptions? In asplenic children, PCV13 and Menactra should not be given at the same visit because the response to 3 or 4 serotypes in the PCV is blunted by simultaneous administration of Menactra. You should give it at least 4 weeks apart. Always PCV13 should be given first, followed by Menactra. This does not apply to MEN-VO, which has a different carrier protein. And this applies only to asplenic children and not to healthy immunocompetent children. The second exception is PCV13 and the conjugate, the polysaccharide vaccine should not be given at the same setting. It has to be separated by at least 8 weeks or 6 to 12 months. Another situation where literally your heart starts really beating very fast. You administer the typhoid conjugate vaccine to a 2-year-old child. Your staff has put the sticker on the immunization record. The patient is waiting for the mandatory 10 to 15 minutes wait. 5 minutes later, the father barges into the clinic and brings to your notice that the vaccine had expired 3 months back and the expired vaccine has been given. What will you do? First, you have to accept that an error has occurred. Don't pass the blame to the staff who has, prepared the injection or anything. Second, you have to apologize because you have made the fault. Third, reassure that no harm will ensure. There is enough data recommendation to show that expired doses will not harm. And lastly, you offer revaccination according to the guidelines, maybe at no extra cost. You can always offer it because this is a very delicate situation and can give you a lot of sleepless nights and also legal troubles, which definitely will not cause any problem, but it will cause a lot of stress and tensions in you. So when will you revaccinate? If it's a live parenteral virus vaccine, either same day or 4 weeks apart, what I just said. If it's an inactivated vaccine, and especially if it's a part of the primary schedule, give it on the same day. If you want to avoid additional doses, where facilities are available and where a correlate of protection exists, you can do the antibody titers 4 weeks later, check for adequacy of the response, and if inadequate, you can then repeat the dose. Now we come to this group of immunocompromised children. We know these children have a much higher susceptibility for infections, and there's a greater need for immunizations. On the other hand, we know because of the immune suppression, lower immunogenicity, lower efficacy, and generally with live vaccine, you can have adverse effects, increased incidence. So how are you going to balance? They need the vaccines, but it may not be very safe. Generally, in severe immunodeficiency, all live vaccines are contraindicated. All inactivated vaccines may be given, but the immunogenicity and efficacy may be slightly lower. For that reason, you may have to give higher doses. You may have to give more number of doses. You may have to check the immunity status post-vaccination, which is usually not done routinely. And you may have to give boosters where they are not necessary. Classical example is hepatitis B. We know that we double the dose in immunocompromised children. A very important is create a shell of protection around the immunocompromised child. Vaccinate everyone around so that the family members who are in closest contact will not transmit the disease. So everyone should receive the MMR, varicella, who are basically eligible to receive it and who are susceptible. MMR, varicella, rotavirus, annual influenza. I have not mentioned Tdap. Tdap should be included. Anyone who has received a varicella vaccine and develops a rash, direct contact should be avoided. If an infant has received rotavirus vaccine, then good hand hygiene should be observed for at least a week, because we know that the rotavirus is excreted in the stools. As far as the pentavalent vaccine, 2 to 3 days. As far as the monovalent, human monovalent vaccine, for more than a week. So hand hygiene has to be observed. Now we come to the next medication, which is probably the commonest cause for giving rise to some doubt about the use of vaccines. That is the use of steroids. So what are the rules? One, in a 10 kg child, if the dose is less than 2 milligram per kilogram, or in a child weighing more than 10 kgs, if the dose is less than 20 milligram per day, there is no immunosuppression. Vaccines can be given, including live vaccines, during therapy. On the other hand, if the same dosage is being given, that is more than 2 milligram per kilogram or more than 20 milligram per day, but if the duration of treatment is less than 2 weeks, there is some degree of immunosuppression, this child can receive all the vaccines immediately after stopping steroids. There is no continued immunosuppression after you stop therapy, because the HPA axis has not got suppressed. On the other hand, if the dose is more than 2 milligram per kilogram or 20 milligram per day, and the duration of therapy is more than 2 weeks, there is suppression of the hypothalamic pituitary axis. No live vaccines till 1 month after stopping steroids. Killed vaccines are safe. If very essential, give it immediately, but it may be less efficacious. You may need to check the response or give additional doses. What we must remember is patients on alternative steroids, inhaled formulation, topical steroids are not suppressed and can receive all the vaccines. So just to recapitulate, 5-year-old severe asthmatic child, 16 kgs, alternate day prednisolone 10 milligram, inhaled fluticasone 400 mcg per day for the last 5 months. His boss for his DPT, MMR, varicella booster. This child can receive all the vaccines because the dose is much lower than what I mentioned. On the other hand, if you have a 5-year boy with nephrotic syndrome, 20 kgs on prednisolone 40 milligram per day for the past 5 weeks, is bought for the same vaccines. You can give DPT because it's inactivated vaccine, but MMR and varicella should not be given for at least 4 weeks after stopping the immunosuppressive dose of steroids. But once the child moves on to alternate day and the duration is more than 4 weeks of alternate days, then he can be given MMR and varicella vaccines. Now a child with juvenile idiopathic arthritis comes to you, 20 kg, he's on methotrexate 6 milligram. The moment you see methotrexate, oh my God, this is immunosuppressant. And this child has come into contact with varicella. Can I give him the vaccine? So what are the recommendations? Children receiving methotrexate at a dosage of less than 0.4 milligram per kilogram per week are not immunosuppressive and can receive all the vaccines. Similarly, azathioprine less than 3 milligram or 6-MP less than 1.5 milligram, they are not immunosuppressive and can receive all the vaccines. I think specifically remove methotrexate because that is a drug which is being very commonly used in JIA. Another relatively new kid on the block is rituximab. This is a anti-B cell antibody, that is anti-CD20. It completely suppresses the B cell population. And this monoclonal antibody is being increasingly used in B cell leukemias and even in many autoimmune diseases where there is hyperactivity of the B cell system. And we are now encountering mothers who are on rituximab, and we are sought for advice regarding what to do about vaccines. Since this is a topic not discussed much, I have included it. Not very common, but worthwhile knowing it. This was a case where I was called upon. 26-year female, unresponsive SLE, on rituximab till 28 weeks. No one gives after 28 weeks. Delivers a normal baby. Can the child receive all the immunizations? What are the recommendations? This causes a complete suppression of all B cell responses, including the immunological responses. So BCG oral polio is contraindicated till 6 months. So you can start only after 6 months. Rotavirus also consider risk-benefit ratio. Inactivated vaccines can be given, but as I said earlier, the response may not be optimal. All live vaccines should be avoided for at least 1 year. Rituximab admitted the mother during breastfeeding is to have very little impact. So if the mother is on rituximab, the baby can be breastfed very safely. Now, what happens if you have a 17-year-old child who is on rituximab? This was the mother. What do you do for the newborn? But here, your own patient. We must remember that following rituximab therapy, there's complete destruction of the B cells, including the memory cells. So you have to restart the entire immunization process. Once the immunoglobulins have returned to normal, which is generally about 6 months after stopping therapy, and you can form your own schedule. Or take a situation where a 6-week infant is brought to you vaccination. As you go into the history, the mother says, I've lost 2 other children in the past. Can you elaborate? No, I don't have details, but one child died at 2 months, the other child died at 5 months. And the doctor said it was an infection, but they could not establish any diagnosis. This is a very, very important red flag. It could be a congenital immunodeficiency. It could be an inborn error of maturation. So it is mandatory that the 6-week-old infant should have a screening for immunodeficiency disorders. A complete blood count should be done. Serum immunoglobulin should be done. NBT should be done. And a lymphocyte subset analysis. If these 4 are normal, you can be fairly confident that there is no immunological deficiency and the child can be given all the vaccines. Don't rush into giving the vaccines. Now, children on chemotherapy, no live vaccines for at least 3 months. Exception is as far as ALL in acute in children with ALL who are exposed to varicella. See, varicella is a very devastating illness in immunocompromised. So we would like to offer protection. So if a child with ALL is on maintenance therapy, remission for more than 1 year, platelet count more than 1 lakh, lymphocyte count more than 700, they can receive the varicella vaccine. You need to stop the chemotherapy 1 week before and 1 week after. It's worthwhile taking this stoppage of chemotherapy versus the risk of varicella infection in this immunocompromised group. Now, many of these children with leukemia come back to us after treatment for follow-up. We must remember that most of the time the memory cells are affected. So for these children, you need to give age-appropriate boosters, even if they have received the boosters in the past. Generally, influenza inactivated can be given after 3 months. Live vaccines you give after 12 months, and most of the inactivated vaccines can be started after 6 months of age. But sometimes if it's a complicated relapsive leukemia, they use what is known as a highly immunosuppressive chemotherapy. In that case, it's almost like a bone marrow transplantation. You got to reinitiate vaccination again. Now, following transplantation, we know that there is total marrow ablation. All the immune competent cells are destroyed, so you have to restart again. Inactivated vaccines after 12 months. Live vaccine after 24 months. Influenza is the only vaccine which you can give earlier, but if graft versus host disease is there, probably you got to wait for a much longer time. Splenectomy. We see children who are posted for splenectomy. Hereditary splenectomy is the commonest cause. Many of them may not have received, may have received only the UIP vaccine. So which are the vaccines that this particular child receives? One is the child should be up to date with all the appropriate, age-appropriate live and inactivated vaccines. Apart from that, there's a special need for pneumococcal. I have mentioned PCV13 because none of the other vaccines are licensed for use beyond 5 years. PCV13 followed 8 weeks later by the polysaccharide 23 valent. This is a high-risk situation, so the gap between PCV13 and PPSV23 is only 8 weeks. Otherwise, it is between 6 and 12 months. The child receives Hib, meningococcal conjugate, and the typhoid conjugate vaccine, which we have in our own country. And you should try to complete the schedule at least 2 weeks prior to the splenectomy. Now, there may be an occasion where an emergency splenectomy has been done, like maybe a road traffic accident. In this case, what you do, after recovery, after the surgery, you give the vaccines. The general consensus is to give after 2 weeks. And why after 2 weeks? Because studies have shown that before 10 days, if you give the vaccine, the immunological responses are not as good as giving the vaccines after 10 to 14 days. So generally, it is given at discharge at 2 weeks post-surgery. Cochlear implant. We are seeing a lot of kids with cochlear implant, with neonatal hearing screening. A lot of kids are coming for cochlear implants. What are the recommendations? We must remember in a cochlear implant, you are perforating the protective bone around the brain. The rate of bacterial meningitis was 189 cases per 100,000 years, almost 30 times greater than that in the overall population. So this child should receive the PCV13, 8 weeks later the polysaccharide vaccine, Haemophilus influenza if he has not received in the past, and the schedule should be completed at least 2 weeks before surgery. Should he receive the meningococcal conjugate vaccine? Evidence says that there is no evidence that people with cochlear implants are more likely to get meningococcal meningitis than people without cochlear implants. You can always, I mean, it's not necessary to give the meningococcal conjugate vaccine. So, in a situation where you encounter an immunocompromised host, follow the proper indications, because it is preferable to immunize the immunocompromised host and obtain a suboptimal response rather than not immunize and have no protection at all. So finally, let's come to one case. A preterm 28 weeks, 1.2 kg, had sepsis, received multiple blood products, PRBC, and at that time IVIG was being given for neonatal sepsis. Now the baby is 26 days of age and stable. What are the recommendations for vaccinations in the nursery? Which vaccines can you offer in the nursery? So basically, in this child, the recommendation, as I said earlier, all age-appropriate vaccines can be given provided as stable. You can give the BCG. You can give the hepatitis B. But you will not give OPV because OPV is a transmissible vaccine. Now, if that infant is still in the nursery at 6 weeks, will you still give the 6 weeks vaccine? Yes, you will give all the vaccines. Only thing is you'll be a little careful about the rotavirus. If the child has an individual room, the child is an individual room with the mother, strict hand hygiene by all the relatives and the nursing staff. So you can give the vaccine, all the vaccines, but rotavirus vaccine, some special precautions. Well, you can give DPT, HIP, IPVPC because they are all inactivated maternal antibodies, facility will not affect. Can we give MMR at 9 months? Yes, you can give because whatever antibodies you have given, passive antibodies to your red blood cell or IVIG, generally the half-life is not more than 3 months. So generally it will not remain in the blood for longer than 6 months. So safely you can give MMR and other live vaccines after the age of 9 months. Well, congenital immunodeficiencies, well, there are quite a few. I will not elaborate on it. This is a graph. Anyone who's interested can take a photo. I will not discuss the details because it's too elaborate, but there are recommendations regarding specific defects. This is available. This chart is available in the Red Book. So anyone can take it. If anyone is interested, I can also send it to them. Thank you very much. If there are any questions, I'll be very willing to answer.
Thank you, sir, for taking us through all the difficult situations. I think there is only one question that you have already answered. Can you give MMR, PCV, DPT, varicella within a time duration of 24 hours? It has been answered.
You can give. I would just one comment on this. What if a child comes for MMR in the morning? You explain about varicella, but he says, I haven't bought the money, I want to take it now. And then he comes in the evening. Can you give me the varicella now? We know that 2 inactivated vaccines should be given on the same day or at least 4 weeks apart. So if he comes in the morning and comes in the evening, is it the same day? Recommendations state that when you say same day, it means the same immunization day. So this child can receive both the vaccines and it will work.
I think we can close the session.
Okay. Thank you very much. Thank you.
President-elect